നെഞ്ചിൽ ചേർക്കും കനിവേ നഗരം മനം കുഞ്ഞോളങ്ങൾ അതിൽ കൈനീട്ടുന്നു ഒരേ ഉൾകിടുന്നു നിണം വിൺതാരങ്ങൾ അത് കൺചിമ്മുന്നു ഒരേ പോയി വായുന്നു ദിനമൊരു സടയിന്റെ ദിനമൊരു every day is a battle here, walking out the door. Bullets bouncing off the wall, kids holding guns instead of dolls. Every day, blood rains, bodies dropping as it falls.
A cake, chocolates और favorite toppings वाला पिज्जा भी और म्यूजिक वो भी सॉर्टेड है आज के लिए मोबाइल पर नॉन स्टॉप एड फ्री म्यूजिक लिसनिंग वो भी लिरिक्स के साथ ऑन Spotify मिनी
One time plans for a day or a week. मोबाइल पर अनलिमिटेड एड फ्री म्यूजिक लिसनिंग एक मोबाइल डिवाइस पर 30 सॉन्ग डाउनलोड्स with lyrics. Try Spotify Mini today at just 25 rupees per week. Terms and conditions apply.
Sound hello, hello.
इधर नहीं उधर नहीं तेरी ओर चले दिल क्यों ये मेरा शोर करे इधर नहीं उधर तेरी ओर चले जरा देर में ये क्या हो गया नजर मिलते ही कहाँ खो गया जरा देर में ये क्या हो गया नजर मिलते ही कहाँ खो गया भीड़ में लोगों की वो है और प्यार के मेले में अकेला कितना हूँ मैं यहाँ दिल क्यों ये मेरा शोर करे दिल क्यों ये मेरा शोर करे इधर नहीं उधर नहीं तेरी ओर चले शुरू हो गई कहानी मेरी मेरे दिल ने बात न मानी मेरी शुरू हो गई कहानी मेरी मेरे दिल ने बात न मानी मेरी हद से भी आगे ये गुजर ही गया खुद भी परेशान हुआ मुझको भी ये कर गया दिल क्यों ये मेरा शोर करे दिल क्यों ये मेरा शोर करे इधर नहीं उधर नहीं तेरी ओर चले
Babe, I saw Karan and Shreya together.
Here's your food.
Yeah, और पता है, they were on the bike.
Ma'am, how's the food?
Good. Yeah, so I was saying.
Ma'am, anything else?
No.
Interruptions are mood spoilers. Try Spotify Premium. Upload your student ID to subscribe and get 50% off plus 1 month free for new subscribers. Tap the banner to know more. Premium student only price per month after. Open only to students at accredited higher education institutions who haven't already tried Premium. Terms and conditions apply.
सड़कों पे चले जब लड़कों के दिलों में तू आग लगा दे बेबी फायर नकली से न करे तू करे जब देखे हमें झूठी लायर काला काला चश्मा जचता तेरे मुखड़े पे जैसे काला दिल जचता है तेरे चिन पे अपनी अदाओं से ज्यादा नहीं तो 10-12 लड़के तो मार ही देती होगी तू दिन में
जैसे 36 फिरते हैं मेरे वर्गी और न होनी वे वर्गी और न होनी वर्गी और न होनी तू मुंडा बिल्कुल देसी है मैं कटदी ना तो सोनी वे और मैं फेड अप हो गई हूं मुंडिया और मैं फेड अप हो गई हूं मुंडिया सुन सुन के
दिलों में तू आग लगा दे बेबी फायर नकली से न करे तू करे जब देखे हमें झूठी लायर
मैं डालू ताल पे भंगड़ा तू भी गिद्दा वाले चले रंग जमा दे हमके बने सभी मत वाले
मन कहे कि मैं ले आऊं चांद और तारे सारे इन हाथों पर मैं चांद रखूं इस मांग में भर दूं तारे
हेलो हेलो तू फ्लोर पे जब है आई येलो येलो बड़ी सॉलिड मस्ती छाई
Check, check. Namaste and a very good morning, dear all. And this is the last and final day of ICVT conducted by SPCIT. Hope you all had a great time yesterday and day before yesterday with all those scientific sessions and cultural programs at the night. And today, let's enjoy the sessions which are remaining. We have 2 sessions today, and each session will be having 6 to 7 topics. And let's start with the first session, pediatric intervention and nightmares. And for the first topic, I would like to invite Ramesh Ritnival. And before that, let me invite the moderators onto the stage, Mr. Mohan, Mr. Radhakrishnan, and Mr. Keshwan. With a big round of applause from who are present here, let's invite the moderators, Mr. Mohan, Mr. Radhakrishnan, and Mr. Keshwan onto the dais, please. Yes. Please take the seats. And the first topic is all about bilateral branch pulmonary artery stenting and pulmonary valve implantation. And in order to present this, let's invite Mr. Ramesh Ratniwal, who is from Apollo Children's Hospital, Tamil Nadu. Let's invite Mr. Ramesh with a big round of applause onto the stage, please, to present this topic. Yes. Thank you.
Good morning, everyone. I am Ramesh Ratnavel, Senior Technologist, Apollo Hospitals. A warm welcome to one and all gathering here. A big thanks to each and everyone present for this occasion. Thanks to ICVT Organizing Committee. Special thanks to Sudhir sir and Suresh sir and Greg Goswami sir, Mogan sir, everyone. Thanks, special thanks. I'm going to my topic. Case history. 11-year-old female from Ghana, born as a second child on non-consanguineous marriage, had 34 weeks with birth weight of 2.8 kg. detected to have heart disease at 1 month of age while evaluating for murmur. So, the cardiac disease, as clear to that, stethoscope only find out the lot of disease, defects, anyone. Case history, underwent top ICR with a transannular patch at the 7 month of age, underwent surgery, bilateral PA plasty with right ventricle to PA conduit using 16 mm Contigra in 2017 while evaluating for increased fatigue and dyspnea on exertion grade 2. Now patient asymptomatic was on regular follow-up. This is a CTPA angio, pulmonary valve conduits as a confluence of the narrowing. Just you can see to that CT image. I can tell him that conventional angio difference. RPA is how to narrowing, LPA is how to the narrowing the origin. Status. Post-redo bilateral PA plasty with the RU2 PA conduit 2017 and then ICR done in the 2012 for TAF. No residual VSD, iota satisfactory, rerouted to LV. Dilated LA, dilated RA and RV with the straightening of intraventricular septum could indicated mild increase the right heart volumes or pressure. Mild calcification in RV to PA conduit. No significant infundibular and proximal conduit narrowing. No significant conduit valvular stenosis, free pulmonary regurgitation. Confluent branch pulmonary arteries with a stenosis involving the distal conduit, anastomosis, distal MPA, main pulmonary artery, at the confluence involving the osteoproximal branch PAS. Measurement of pulmonary vein to pulmonary valve to main pulmonary artery access and the branch PAS as a detailed above. No significant proximity of coronary to proximal conduits, pulmonary valve annulus level. Proximality of left main to distal MPA confluence narrowing the region. Bilateral SVC, right aortic arch, no PDA coarctation, no MAPCAS. This is the bilateral branch PA stenting angio plus or minus pulmonary valve implantation. This is view for RAO 30, cranial 30. Is especially pulmonary valve implantation and then RUOT stenting view. This view is better and suggested. Recommended views. After take the lateral views. This is measured that pulmonary valve size is 19 mm, so 30 mm for the length. Bilateral lateral angio. Sorry. This is bilateral PA entry, OS and sheath. Sorry, this is for the trim video cutters and cut the images, not more than 100 MB, that reason, sorry. This is for JPEG image, LAO 15 and cranial 40. This is to the, ideally recommend to this view for LPA and PA origins and seeing the branches. Wires and strengths entry for this view. This view for strength positioning. This strength deployment. So 23 mm Z5 strength, 12 into 40 cook balloon crimped. Over the crimped 1240 cook balloon and then 23 mm for Z5 strength. Z5 strength is for large size. First deployed that LPA. can see how tight narrowing in the origin of RPA. Just so you can see to here, pacing lead is there. Where is the pacing lead? That pacing for I can took that in pulmonary valve implantation, LV pacing. So I am doing it differently in that LV pacing. So what is the reason I can tell you? Post dilated for the both balloon, bilateral. It's a Atlas Gold 12 to 40. This is the balloon for the high pressure balloon. It's a post angio. So now you can see bilateral branch PA is nicely filling. Now desire to that pulmonary valve implantation. Pulmonary valve was taken that 19 mm measure, so 20% extra recommendation that company was venous side. So 23 mm my valve taken. It's a valve is entry. Native valve is for native valve pulmonary valve implantation, not RUOT stenting. Previously doing to that RUOT stenting after inside the valve implantations only. So now is doing that my valve, Meridien. This valve was doing to that native valve implantations. I'm doing to 32 mm valve also, largest valve in that my valve only available. Now we're doing to that 280 for pacing, LV pacing, rapid pacing. Now see that angio, post angio, bilateral PA branches nicely seen, and no PR. Sir, some more is there. Sorry, sir. No PR, no paravalvular leak. I can show this slide, sir. So small baby, so that reason only I can present this. So cath lab hardware. Please, all technologists, you have in the cath lab inside the hardware for covered stents. Compulsory, you can take the RUOT stenting or LPA stenting, coarctation of stenting. Anyone you can take, and then iliac also, iliac artery and iliac vein also, you can put the peripheral stents also, cover stents. Compulsory, you have the cover stents, you have your cath lab room, that only you can put the patient in cath lab table. Otherwise, you don't have the stents, you can tell him your consultant, and then backup for the surgeries also, and then or otherwise you got the stents for today or tomorrow, postpone the case. That's a manner of cover stent, very important. Six is a backup purpose. Compulsory you have to that cover stent needed. 6 French sheath for 3 numbers, 7 French sheath 1. Why take the 7 French sheath for? 7 French take for the right femoral vein. This is crossing to that LPA, so deeply positioning to the wire. This 7 French guiding catheter only coordinate with that 2 wires, Landerquist wire and then 1 thermo wires or Teflon wires. Which one you can take? 2 wires recommendation, this 7 French guiding catheter only, Jenkins right. Guide wire 250 angle and 260 cm plus extra stiff guide wire, Landerquist 260 cm guide wire, 014 guide wire. Why you take to the 14 guide wire? This is taking that compressing the coronary arteries. You can put the LAD or RCA, which actually is compression that pulmonary valve implantation. That time put the coronary wire for backup in that vessel. That's the reason you can your cath lab in that 14 coronary wire also. Catheters Jenkins site and 2 numbers. 2 numbers Jenkins site for bilateral branch PA entry. MPA and 7 French guiding catheter pigtail temporary lead for balloon tip preferably better. Pulse generator, please check the battery. Reason for using rapid pacing, and then every day you can do this job. Just I can remind you. Hardware balloon 12 to 40 Cook advanced low profile balloon 2 numbers. Zephyr stent 23 mm length 2 numbers. Atlas gold balloon post dilatation 12 to 40. Reason for the high pressure. Myval Meridien 23 mm made in India. 23 into 30 navigator. Python sheath 14 French sheath. Covered stent all size backup including the peripheral stents also covered. Summary. Already 2 times surgery was done. Now high risk for the redo surgery complications. Recovery also high risk. Explain intervention complications and taken video counseling. Procedure. Video counseling all patients, high-risk patients taken is the safer way. Just you can check with the technologist also. He is in the one of the part in the consent. Just you can check anesthesia consent is available or general consent is available, high risk consent is available. You only know that is a high risk case or normal case. Any normal cases also doing to that. Just adult patients, patients signature and then attender signatures also compulsory. Please check this compulsory. Procedure was done successfully 2 hours. Patient shifted to recovery room 4 hours observation. Then shifted back to ward discharge without any complications after 2 days. So thank you. Next. Now going to bilateral branch PS stenting. An 1-year-old diagnosed have heart disease at 3 months of age, baby of underwent tough ICR 7 months of age. On evaluation found to have the severe branch PS stenosis, birth weight was 2.6 kg, first child. First history of February 2022, tough ICRs done. Clinical diagnosis, VSD closure plus RV to PA conduit plus LPA plasty, done on February 2022. For pulmonary ectasia with a large subaortic malign VSD. Small PDA shunting, left to right supplying branch PAS and duct-dependent pulmonary circulations. Severe bilateral branch PAS stenosis, no residual VSD. Procedure, right femoral artery, right femoral vein, left femoral vein. RV injection was done, LAO 15 and cranial 40. Lateral view, MPA injection, LAO 15, caudal 45. These views are recommended, just I can tell him to that. Lateral, LPA ballooning was 3.5. Why I will take that coronary balloon? So sheath guiding catheter introducing to the catheter. This is I can tell you one technique is NC Solaris balloons was advanced with the over 5 French guiding catheter and 1/4 run-through wire position across the LPA origin inflated to 12 atmosphere 10 seconds. First, at the origin and lateral distal LPA, RPS stenting 9 into 20 mm, LPS stenting 6 into 20 mm, Cook formula stents. You can see angios. RV angio, LO 15 cranial 40. This is for lateral view. This way you can see RPA how is the narrowing and then LPA is not visible. LPA crossing, you can see that first image, distally balloon is positioning, coronary wire. So coronary balloon was inflated, pushing the guiding catheter, is a supporting. Otherwise, guiding catheter is not going to that distal LPA. You can see in the distal LPA balloon was inflated after pushing the guiding catheter. Now crossing the sheath also, LPA distally. Now RPA and LPA crossing the sheath, stents was deployed. First stent was deployed in the LPA. After deploying for RPA stents. So 620 is a smaller LPA. Is a is the pre-pressure and post-pressure. Pre-pressure for the aortic pressure 9150, mean of 66, RV was 83. Post-stenting, aortic pressure 111, 60, mean of 81. RV was 45. Half systemic of less than RV pressure. Post-angio. Now see. So left lung also filling nicely. Cath hardware sheath and 5 French sheath, 7 French rabbit sheath. So maximum 5 to 7 French rabbit sheath. So reason for I am using the Cook formula stents. This is recommended maximum recommendation 7 French sheath. That's why I am keep gradually 55 centimeter, 70 centimeter, 90 centimeter. 5 French, 6 French, 7 French. 3 sheets I have the backup. And then Balkan sheath also I have it. Reason backup. I am using or not using is a secondary. Is the material is inside the cath lab is a backup purpose compulsory. So you have to the difficulty in the rabbit sheet is a Balkan for curved for 40 degree to 90 degree. So it is a support with you. Pigtail and jackins, right, guiding catheters, thermo guide wire and 1/4 guide wire, Amplats extra stiff guide wire 260, 1/8 guide wire. Is a 8 mm and 7 mm strengths, 6 mm, 5 mm strengths also, 1/8 wire only comfortability. So I am pushing to that 1/4 wire only, still now I am doing. NC coronary balloon 3 into 3.5, 4 mm into 20. So mostly I am using for that guiding catheter pushing technique and hold the distally. There's a long length balloon 4 into 20 mm coronary balloons. Cook formula decided the pre-procedure size. I have the strengths ready in the cath lab 5 mm to 10 mm, all sizes, all lengths. What is the availability in the company is in the available into the my lab in the that day. Which sizes I have to the 20 or 30 stances and the 30 stances I have been put in the my lab. Any other stances not there, and what sizes is not there, I have to the backup any other brands. This is the other brands and they recommend for sheath size is big. So smaller baby, I want for which is strength was smaller size sheath. This is I am choosing the strengths. Avoid to redo surgery, major complication and mortality, left lung protected after inversion. Well, intervention. Well, saturation improved, explained on LPA crossing technique, angio views, minimize the radiation dose. Thanks. Finally.
Thank you, Mr. Wright. Both cases are very excellent case. And first case, why you have faced the LV pace?
Sir, RUS know the space. I am taking the sheet, no, valve. It's a 14 French sheet. Valve is going to, he is facing to, this displace the leads. That reason I am putting that here to LV. So it's a safely. I am pushing to not directly in the LV, sir. First crossing to the LV. After pushing to 6 French sheet in the rabbit sheet in the LV. Thereafter, rabbit sheet I will be kept in that 90 centimeter length. So pacing lead length is 110. I'll be put that LV lead after push it out that rabbit sheet in the ascending aorta above the aortic valve. So that reason only I'm pacing and still 282 to 300 also small babies I'm pacing and the blood pressure is dropping, valve is not moving and that standing position also, sir. That reason I'm pacing to LV, sir.
No, instead of to LV pace you can do RV pace only from jugular we can go. It will not disturb.
Yes, sir. All patients not going to the jugular, no, sir.
Rapid pace, sir. No, access only. Access, no, to access they have taken already. To RV, the jugular access they can take. No, LV,
no, sir. Sir, anesthetic side take that REJV, sir.
LV pacing we have to go for a high threshold. RV threshold you can do it less. High threshold we have to pace.
Yes,
Small baby, either rapid pacing, you can jugular access you can go. Through access you have taken from femoral.
Yes, sir.
Python says okay, you need not use another access. You can go with the jugular access and pace.
Pacing that last 2 or 3 cases.
Okay.
Okay, sir.
Then that's okay. Then 14 French Python went easily for the small baby.
Yes, sir. So it's a 11-year baby. I am putting just I can tell him, sir. Baby weight more than 17 kgs, I can put in the 14 French sheets, sir.
The 14 French sheets.
14 French sheets, sir.
Any dissection was there?
Still now I'm not 10 years I will be managed in the pediatric cases access and adult also. Vein access I will be recommended, sir. I am asking with at the same time T also, sir. Pediatric and adult probe is there. So large ASD I will put the T. So doctors also asking. I am asking, sir. Baby is below 25 kg. I have the adult probe only. I am not giving that, sir. No, patient 24 kgs. So any computers came is possible, sir. And then I am telling you to the GA giving to the anesthetist also. Ma'am, baby weight is 24 kg. So I recommend for above the 25 kg only adult TU probe recommendation. So same time doctors give to the 14 French sheet. So baby weight for only 12 kg.
Thank you. And the first case you have pre-dilated the pulmonary artery or directly you have taken stent. Here that pre-dilatation slide is not there.
Not, sir. I'm not doing the pre-dilatation, sir.
No, why? Because this pulmonary artery is very fibrotic. You have seen, even stent was not opening.
Yeah, yes, sir.
In that situation, it's very difficult. Why you are not dilated the pulmonary artery? This is fibrotic lesion. Almost this pulmonary artery is very rigid.
So this baby will
Sometimes stent will not open. You have seen there, see, stent was not opening at all. You have post dilated, it's okay. Sometimes hourglass will be there. You can't take the non-compliant balloon after stenting.
Sir, I'm
better to pre-dilate and go. Nothing will happen.
Sure, sir.
Why to take risk in the baby?
Sure, sir. Sure, sir.
Yes, sir. Any comment? Bifurcation stenting, both. They can
Sir,
two balloon dimensional they can take.
Sir, 7 French, 7 French, 14 French sheath is going to.
Yes, correct. Now I am telling before stenting, why not dilated with the balloon? Yeah. No, only see, should not, no. See, because this is a fibrotic, not like a coronary, this one. So, first you dilate with a non-compliant balloon, keep 2 wires, 2 balloon only, no problem. One after one you can dilate. Why directly take the stent? Because sometimes it won't open. See, it's a fibrotic, this one, the stent will not open, then you can't take the balloon also through the stent. It's a fibrotic. Hourglass will be there, then stent, balloon, non-compliant balloon won't go. It's a bulky balloon. So on the semi-compliant and non-compliant balloon you can cross, but non-compliant balloon won't go.
Sir,
at that time you have to pre-dilate and go better.
No, Dr. Shivkumar might have been taken or addressed all. I think he is having his own other.
This is why
both the stents he wanted to take it and
directly they have taken no problem. Directly they can 2 stents simultaneously. They have deployed. That's all correct. But free dilatation, better to go with the pre-dilatation. It is a very rigid pulmonary, this one, post-surgery and fibrotic. And it was not opening at all. This stent was not opening.
LPA stenting, LPA was opened properly. The
RPA opened very nicely, but LPA was not opening. Stent was not.
Correct.
If there is still construction is there, we can't take the balloon, post-dilatation balloon. That is my...
Yes, sir, I can tell him, sir.
Ratnanvel, for LV pacing, use the balloon tip pacing wire.
Balloon tip pacing only.
Excellent.
Balloon tip pacing only.
Yeah, that is okay. That we have done is correct.
Sir, no 1 second, sir. I am telling him frankly that LPA and RPA I'll be doing the multiple times in the post-dilatation. And 12, 40 balloon and 40, 2 to 3 times I am post-dilatation. He is not still opening. So that same balloon I also downstairs. This is I'm not put the video here.
Maybe no, I'm not.
And then all patients I will be doing that pulmonary valve implantations. I have the 30 into 5, 5 centimeter Z-med balloon. This is for the inflating. Waste is came stop. So measure the unless area, valve area. After only deciding, sir. So okay, sir. I'll go to next, sir.
Yes, sir, Ratnavel. Very nice case presentations.
Thank you, sir. Thanks, sir.
Ratnavel, one more question.
Yes, sir.
How was the post-procedure femoral access was managed? Because small child, multiple sheets were put. Whether manual compression given or any...
Sir, venous, I will put the figure of 8, sir. My
cut
doctor.
Down technique you did or what is it?
Or consultant.
No, cut down.
No cut down, sir.
Percutaneous only.
Percutaneous only. Sheath taking and then he is putting that.
Nice.
For venous access, no problem.
Venous access only, sir.
Yeah. Then one more. You have used a Linderquist wire. You have in your slide that Linderquist wire was there. You have for the small baby, is it recommended for Linderquist wire?
Born baby not recommended the Linderquist wire, sir.
Okay, you have not taken it. But in your slide it was there.
So it's 11-year-old, sir.
Yeah, it is not because normally in pediatric we won't take ultra stiff wire. Normally
extra stiff wire.
Extra stiff wire can be taken, but that is ultra stiff wire. Linderquist is the ultra stiff wire. If you take, it is very difficult. Sometimes it will bend, then we can't pull it at all.
Sure,
then we have suffered so many times.
Sure, sir.
Then pediatric cases, better to take only maximum stiff wire. That also should not take, but sometimes for deploying valve and we have to take. But only employs extra tip, not the linear cruise wire or ultra strip wire.
Yes, sir.
No, now
This
10
is I can tell.
10 cm, shaft tip also is there in
Yes,
the
it's
ampulated wire.
7 centimeters soft tip in that
Yeah,
Boston Scientific
correct.
and plus extra strip wire is a blue color. It's a Cook company for the 3 centimeter. I am preferably pediatrics. I will use only that plus
Yes,
extra
yes,
strip wire
that's
Cook
correct.
3 centimeters. Sir. Thank you, sir.
Thank you, Ratna.
I'm going to now coarctation of aorta with PDA. It's a loss, sir. Sorry. And a 20-year-old old male, 2 years back, incidentally intermittent palpitation and chest pain. Chest pain not associated with the sweating, no history of the syncope and leg pain. Clinical diagnosis, severe post-subclavian coarctation of aorta, PDA, concentric LVH with a good function. Upper limb pressure 160/70, mean of 96. Lower limb pressure 95/60, mean of 78. Procedure, descending aortography using the 5 French pigtail catheter in a lateral view showed the discrete post-subclavian coarctation of aorta and a moderate PDA. The coax segment was 40 mm, transverse arch to diameter was 15 mm and dia, and the length of B stented was 38 mm. PDA device closure, right femoral vein access, descending aortogram in the lateral view using 5 French pigtail catheter showed a moderate size PDA measuring about 4 mm at the pulmonary end and a 9 mm ampulla and end. It was a used 12/10 LifeTech PDA occluded. PDA was crossed anterogradely using 5 French pigtail catheter and O35 wire thermo wire. So that time always all the technicians keep the straight wire also. PDA crossing, you can use angle thermo wire first try. So you can take that time, you can use it the straight wire. You can give the recommend to the sir, just try to straight wire, sir. So this is for easily crossing in the straight wires. Thermo wire combination, thermo wire was exchanged for 260 centimeter plus extra strip wire. Ground sheath was upgraded to 9 French LifeTech delivery system. Lateral angiography. This is not seen into the coarctation of aorta clearly. So I'll show to one more view have that. Through the sheath, 12/10 mm LifeTech PDA occluded device was passed and deployed under transthoracic echo and the fluoroscopy guidance. Showed the no residual shunt through the device. Now you can see this is a LAO 70 cranial 20. This is I can see you can see that coarctation of. Now stent entry. Now stent was deployed. This post burning, post -angio. No residual. PD device not still deployed, delivered. Always coarctation stenting of done after you can check the AP view. Is any dissection any is there? You can check the AP view confirmation after only come out take the pigtail outs. Still now PD device was not deployed. PD device was now releasing. This is a post angio. So you can see. Cat the hardware, sheath, 2 numbers, pigtail, jackins right, and multipurpose, as usual, same things. Guide wire 035 and 150, amperes extra stiff wire, 260 long sheath, example, LifeTech delivery system and mullen sheath, pacing lead, pulse generator, cover stent in the backup always, bib balloon, zephyr. Some always you can use to that coarctation of stenting, bib balloon. This is adjust to that place, big balloon. It's an inner balloon inflated. You have to any doubts in and that time you can move just a little bit move to the adjust to that big balloon is using to the over the stent crimping. Big balloon is always recommended is better, I think. Big balloon and Zephyr XL stent. Here is XL stent using to. This is for going to up to 25 mm in that Zephyr stent. 8 mm to 25 mm dilated, post dilation. Summary: PDA coarctation can have pulmonary hypertension does not happen. However, coexist the PDA if coac is severe. Covered stent is the treatment choice. Residual PDA can happen. Cost is a concern. PDA device or bare metal stent cost is effective by complete closure. Always have a cover stent backup. Thank you. Thanks. Give to this platform everyone and ICVT teams. Again, I can tell you. So thanks.
Thank you, sir. It is a the wonderful presentation. Nice case also.
Thank you, sir.
Instead of using one PDA device and one stent, you can use cover stent only.
So cover stents I have.
Not necessary to use this one.
Yes, sir. I can tell him this frankly. My Tamil Nadu is very poor peoples. So I am fundraising and then government scheme. So government scheme giving to that PDA device closure only 49,000. So device cost is 36,000.
Plus another one 60,000.
Sir?
It will be 90,000, both including.
Now is finished for same quotation of hydra, everything done in a single plus on the fundraising platform, sir.
No.
So that stent also in that trial time. So this is give to that half of concession and trial stents also, sir.
No, it's okay. Then
That's reason
then it's okay. No, instead of using one PDA, it will be around 39,000, and one stent is 60, it will be around 90,000. In that concern I asked.
Yes, sir.
I know we are also doing this poor this one, but it's okay. It's free of cost if you are doing. It's very good. Nice case also.
Thank
But
you, sir.
in my concern, instead of using this one, you can use a cover stent, only one cover stent.
Yes, sir.
Cost
I have
around
to.
90,000.
Yes, sir. That patient also video is there in the 6-year-old obvious patient name. So this is I'm putting the same PDA. I'll be in that 34 mm cover stent. I can use in same company as Zephyr.
Yeah.
So that is cost for 2.2 something, sir. Thank
Okay,
you, sir.
thank you. It's well done. All three cases are very nice and well done also.
Thank you, sir. Thank you so much, sir.
Thank
Thanks,
you,
sir.
sir. Thanks.
Thanks for everyone.
Thank you. Mr. Ramesh, please be on the stage and receive a memento from the moderators, please. I request Mr. Mohan to please present the memento to Mr. Ramesh for his excellent presentation. Thank you. Big round of applauses, please. Yeah. And for the next topic, let's invite one more moderator onto the dais, please. With big round of applause, let us invite Dr. Priyank Modi to join the stage with them as a moderator. Dr. Priyank Modi. Yes. Please be generous in giving the claps because it's the last and final day of the conference. Yeah. And the next topic is about primary PCI, a different ball game, optimizing outcomes. And to present this, let us invite Dr. Jay Gopal from Lakshmi Hospital, Palakkad, and he's available online.
Ready?
It's ready. Sir, good morning, Jay Gopal, sir. I'm on here.
Yeah, good morning, Mohan. How are you? Thanks for inviting me.
So can you please unmute the mic?
Can you hear me?
Hello. Good morning,
Yeah,
sir.
good morning. Can you hear me?
Yeah. Jay Gopal, sir, I'm on here. Sir, please.
Yeah, Mohan, hope I'm audible. Okay. Is the next presentation there, Dr. Pinky, or I'm doing it? Sorry, can I go ahead? Okay. So just share my screen. Hope my slides are visible. Okay. Yeah. Good morning, everyone. And in fact, I'm delighted to be here as part of the Cardiovascular Technicians annual conference. I must congratulate all the office bearers for a wonderful show in getting this meeting in progress. So I thought I would when I was approached to speak on a topic, I thought I would probably discuss an area which is probably the most relevant and widely done procedure in the interventional arena, and that is what is the primary angioplasty or the PAMI. So I'm sure people right from the beginners to all the seniors might be doing a lot of cases, but over the years, the accumulating experience over a long period of time, I probably would share some of my experiences and also give some insight to the technicians as well as to some of the junior people here as to what one should do in optimizing the outcomes. All of us know that when you do, it has to be a very fast procedure, a safe as well as a successful procedure. The idea is to get a TIMI-3 flow, an adequate flow, reperfusion in time, and within the usual stipulated period of less than 90 minutes, which is the universally recommended following a diagnosis of active myocardial infarction. But at the same time, we also should not land up in complications like an access site bleeding. And more importantly, I think the emphasis of my talk would be how to avoid the slow flow and the no flow in the setting of a primary PCI. Now, I think there is no debate today that the radial interventionalists outnumber the femoralists. In fact, we all know it's very comfortable for the patient. There's less bleeding. Though in earlier days, we used to be really worried about the excess bleed with the use of glycoprotein 2B, 3A, sometimes following a thrombolysis. You have to do a procedure within 3 hours. So the radial has become so useful, but it's not that it is devoid of complications. Sometimes you land up in problem with hematoma. In fact, we have had a couple of pseudoaneurysms also. But by and large, it's very easy to do a radial. But then femoral access is often something which should not be forgotten. And I think the threshold to switch over to femoral should be extremely low. I think that is what everyone should keep in mind, particularly when you have a very complex case where you need to really do it in a timely fashion with good result. And also, one should also be thinking of a hemodynamic support. So the issue is that when you need a hemodynamic or when you have a very difficult access, for example, radial where there is a lusoria or when there is a toxicity, one may have to resort to a radial approach. I think, I would agree with most of the people sitting here that the default strategy is radial. I also, 99% of my cases are radial. Femoral only when I have a very sick patient, for example, an anterior wall myocardial infarction, where I might put in some of the hemodynamic IABP or so, or sometimes when you have a complete heart block, you need to pace. But the routine practice now, I have started switching over to the 7F, the 6 French sheathless guide, because in which case, sometimes, even in a acute myocardial infarction, you have a complex situation like a left main or a bifurcation where you may have to use 2 stents, and then you need a much larger guide catheter. By and large, again, many people use the Terumo as I would rather think in terms of taking a O35 wire initially to navigate my guide as well as the diagnostics. And then very rarely I would go for a Terumo when you have a thin radial and a young female, because this is actually a little more traumatic as well in some cases which have been shown elsewhere. But again, I would advise all the people that, for example, you have an anterior wall MI, you should see what the right is like. Look at the collaterals also. If it's possible, the patient is stable. Otherwise, we are very sick, and I'm very sure that the left anterior descending artery, for example, a sick anterior wall myocardial infarction, I don't want the radial to get into spasm. I don't want to wait for too much time. I would rather straight away use an EBU, which is my default, and then go ahead with the procedure. Some people might argue, why not use a single guide? For example, the Terumo has a single guide, this thing. But I think it's also important that we must also, when you do a femoral, we sometimes when you have a tortuous route, the idea here is just to show you that if you have a long sheath, in fact, it's so much easier to hook the arteries. And for example, this is a very sick patient where you could finish off without too much of a problem. But then the guide catheter cannulation can be sometimes very tricky. For example, if you're using a radial, when you have a tortuous subclavian, I often use the use of a stiffer wire to help navigate and then to get it into the coronary without much of a contrast, or more so in the dilated aorta. And sometimes, when you, I mean, rarely have I used a single guide catheter, the one which is marked by Federal. But I must be honest and tell you that I've had problems with this, because this is not like the conventional EBUs and where it's got an automatic trip. But this, in fact, I had a very elderly lady with an RCA dissection which went all the way up to the aorta. But fortunately, I was able to tack up the dissection immediately with the stent and get out. So I think this is something which one must notice, and it should only be used single guide in experienced hands. Now, the problem comes when you are not able to engage the coronary. So what do you do in this situation? For example, somebody has taken a shoot to the tiger and you find you've got a good diagnostic. You are very easy and you think that you can do the procedure, but then there's no way that you would reach the ostium with the guide. So in that case, one of the tricks that you could do is wire using the diagnostic, leave a wire there, and then slowly exchange carefully with the guide catheter. Or what I do when sometimes I don't approach the ostium. For example, I have to do an LAD and I find the circ is there. I would rather put initially a wire into the left coronary, then gently pull back the wire and push the guide, and then this will really sit in place. And these are simple tricks to help you guide the guiding catheter in place. And sometimes when it's not possible, don't waste too much of your time, move over to the femoral route. But then the problem is that in Saras, sometimes mostly I use the EBU for the left, and it's become a standard practice. Within no time you could get in. But sometimes when you have a very short left main, you might have to take the Judkins also for the help. But the right is even more trickier. For example, you have the origins where the right looks down. I would rather think in terms of using a multipurpose there. When it's looking up, the AL, again, the worry of dissection. But sometimes you might need something like the guideliner support, which will come to a little later on. There have been instances where, you suddenly in an acute MI, you see an anomalous right coming from the left, in which case, sometimes the Judkins or the EBU might be of help. I just wanted to share one of my cases here. This is actually one of my patients who had an inferior wall MI. The left is coming from the right. No catheter would get in there. And in fact, even the amplexer was not sitting well. And in fact, this is one case where I went through the femoral route, got in a Termo, the single catheter again, and that gave excellent support. And you could see the long stent, which is beautifully tracked, and the outcome was good. Sometimes when you don't have a guideliner, you can pre-shape your guide. Maybe you could take a GR4 into the right, can use it to deep intubate. Make sure that you don't create a dissection, but these are simple techniques where you can manipulate. And then rather than the pushing, it should be the talking movement, which should be helpful to get you inside the coronaries. But sometimes we know that this may not be sufficient. You might need, you might have to have a little more support to guide the balloon or the stent where you can use the guide extensions like the guide Scylla or the guideliner. This is a very, very tough case I had. In fact, patient had a very long lesion, and then there was a very significant lesion there in the mid part. I was able to, you could see that the Judkins right was the catheter used, and then the balloon would go there, but then it not even get into the area where it needed a post-dilatation of the first stent. And so what I did was again got the guide Scylla in, and with that, it could easily go inside. The balloon could go inside. You could see where the waist is. It could be dilated. And not only that, second time when you needed a stent, it easily could track in, and then you could get a good result at the end of the day. So again, another proximal stent was deployed, and this finally needed an opium balloon at 35 atmospheres to open up the mid portion of the stent. So these are important tricks and tips where the threshold for crossing over a good guide support is mandatory in primary PC, and without wasting too much time, that should be the way to go about. A little bit of wiring in acute myocardial infarction. Many people, when they find that the wire doesn't easily go in, we must all realize that in PAMI, it's an acute occlusion. It may not be all that fibrotic unless it's a little few days old. Many people, they resort to the stiffer wire. I would rather discourage this. In fact, I would go for a new wire, get a balloon support. If that doesn't work, 99 out of 100 times, I would get a whisper or a hydrophilic wire through. And this actually has been in my pattern. And this is to be seen, to be believed. And not only that, when you have a dissection, for example, created by one wire, leave that wire there. use a hydrophilic wire to get in. And this sometimes has been a savior. So I think in the lab, the Whisper and the Neo wires has to be in the shelf all the time. The problem comes where sometimes you are not able to wire it through the true lumen and it might go to a different lumen, but then you find that there's a side branch. So don't be frustrated. Immediately, whatever it goes in, gets into the side branch, and then maybe open it up a little bit into the side branch. That will actually tack up the way. And then you'll be able to, with an angle wire, you might be able to easily get in and then dilate into the concerned area and then stent it pretty well. So these are all simple measures which will actually save you a lot of time and get you the desired results. The other important thing is when you have an acute anterior wall MI, you suddenly see that there's either a minimal left main or an ostial occlusion, where you are wondering whether you need a crossover stent or just an ostial perfect stenting. So the first step I would say is wiring the L6 is mandatory. In an acute MI, again this is one patient which I wanted to show you, large dominant circumflex. You don't know where really the ostium of the LAD is. You know how difficult it is to get with the wire, but with even the floppy wire with a balloon support, I was able to get through, negotiate. And then you find that at the end of the day, there's a lot of thrombus there. And one important thing which I also always convey is that I initially had to get in a 1 millimeter balloon. You could see the single marker there. Subsequently, my pattern is once I understand the length of this thing, I would actually take a longer balloon. In fact, I would keep all the longer balloons, the 2 millimeter longer balloons. Today, you have the 2 millimeter stent, all these 10 balloons there, where this can easily cover the interior. The idea is to have a lesser number of dilatation to prevent the no flow, the reflow. So you could say even with the long balloon, you could see there is some amount of slow flow there. So, but then the second wire here not only protects the circumflex, but gives you a perfect marker, lesser contrast to find out where exactly the ostium is. And then you see that once it is done, the results are pretty good and that you finish off the case. As a word about pre-dilatation. So once wire is crossed, I think the first step, many people don't do that. The immediate this thing is go blow up with the balloon with 10 or 12. No, that's not the way to do it. Once your wire crosses, try to estimate the lesion length. Just take a puff and see. Sometimes your wire itself has opened up. And if you find that the lesion is about 12 or 14, you can always, as I had mentioned earlier, keep some balloons of the adequate size. Use a longer balloon and then you see whether the ends are covered. And then even with an uninflated balloon, sometimes you can visualize. And that's one easy method to see that you do less of pre-dilatation but adequate sizing, and that really translates into less slow flow. But there are sometimes in larger arteries where you find tight stenotic lesions. In that case, if you really think it's a fibrous stenotic lesion on top of which you had an MI, use a 1:2 balloon size and thus aggressively. So if you pre-dilate well, an aggressive post-dilatation is not required, and that actually reduces the slow flow. So these are simple tips in the context of primary PCI, balloon dilatation. Now, sometimes you open up, but then you find that after balloon dilatation, there is no distal opacification. What do? Don't be panicked. You keep the uninflated balloon there, and then again, just a 1 mm or less than that puff. Even if you still don't find anything, immediately change over to microcatheter or an export, and then give a small injection. You will find the distal vessel opening up. In which case, you are fairly sure the distal vessel is fine. Now you will be able to find out the decide about the length of the stent, and you could directly go over the stent. And when you find a thrombus, I think this is a very important thing. For example, you open with a 10 millimeter balloon, you find the thrombus is extending 2 millimeter. Take a longer stent, and that really helps in tackling the thrombus and also to preventing further slow flow, because the entire thrombus gets trapped, and then that would convert into a good result at the end of the procedure. You must use tirofiban. My practice, use it when you find thrombus, but in a select few cases, which is my favorite area of research and topic, is an intracoronary lytic therapy. So this is one case I show here where you see the LMCA, the right is good. The LMCA has a very tight lesion. He was very unstable, came with an anterior MI. You find that there is no lesion, there is no flow in the middle LAD. That is what it is. And then you find that so in these cases, when I know that I had to open up the left main, before wiring, I keep the balloon mounted on the wire, and then on the wire, and then as soon as I cross it, dilate. But then here, what happened was after the stenting, there was a slow flow. So then, there is a left main, but of course, most important step at this point of time, apart from giving a vasodilate intracoronary thrombosis, is to understand that the filling of the coronary has to be perfect. You see that the left main might look insignificant, but what I did was just open up the left main, and then subsequent stenting, you see the kind of flow that you're getting. So after the stenting, for the previous stenting, and after that was stacked up, got a TIMI 3 flow. So all this slow flow, everything disappeared, and that actually translated into clinical benefit within a short time for this given patient. But now the question is, many people, the moment you see thrombus, the default strategy, you have a knee-jerk reaction of putting in a device in export or whatever, thrombustor, and then try to pull it out. Today, one must clearly realize, I mean, I hardly ever used this. I don't say that I deny using, I don't deny that I use it. It's a class 2B. But then there are a few tips when you use the guide. I think make sure as a technician that you see that if it's a right coronary, which is more often the case, it is very well engaged. Aspiration 2 centimeters before lesion, multiple slow passages. I always keep the tubules open when I do it and stop at the thrombus site. Continue distal to the occlusion. And once you take it out, when you sucked it out, just look for thrombus in the filter. Sometimes we are not able to push the export, in which case you might have to do a pre-dilate with a low pressure balloon. And thrombosuction in my practice is the first important step is the duration. Somebody comes to you after 2 days after MI. I'm fairly sure the thrombus is organized. Whatever the medications that you give will not work. In that case, when you have a large thrombus burden, I would use a suction device. I would try to avoid this in proximally, very proximal, because you will pull it back into the left main, and that might go to the circumflex, which will also get compromised. But it's more often in the RC, as I had mentioned earlier. It's rather seldom used in cases today. So when you have a guide where the algorithm is thrombectomy, TIMI 031, 0 or 1, small prelude dilatation stenting. If it's a 2 to 3, small thrombus burden, direct stenting, large thrombus burden, and a small mid-vessel size, one would actually go into a device there. This is one of the patients who came 48 hours after an infraposterior MI. You could see the extent of thrombus there. So in this case, after wiring itself, there was a relief, and then I had no hesitation because a large ectatic vessel. When you find a large chunk of thrombus, I would always use an export there, and that actually after the stenting, you could see the results were definitely better. And not only that, once you do this, I think the most important step would be the sizing of the stent, where plan use of an adequate size. Shorter stents often has a low reflow. Longer stents, as I had mentioned, if you find thrombus. But one word of caution is that you often underestimate the size in acute myocardial infarction because of the neurohormone response, and always try to deploy at a nominal. And the most important thing is a post-dilatation. You need a good, well-dilated stent, perfectly apposed stent, but then remember, perfection sometimes can misfire. First priority is a safe procedure. Post-dilatation, if it is under-deployed. If after deployment, slow flow, don't try to do it. You can always bring in back this patient 24 to 48 hours later once the hemodynamic improves. So the message is, if you want to prevent slow flow, less manipulation of wires and balloons, plan pre-dilatation, liberal use of intracoronary Nicoran. This has made a huge difference. Minimal pre-dilatation, appropriate new generation stents, and most important, prevent edge dissection. Don't go to high pressure with your stent or try to open with the stent once or twice. This actually leads to slow flow. And puff after stenting, sometimes appropriate length and size to the non-compliant balloons is again very important. Don't try to oversize in an acute MI. And treatment, once you have it, you must understand that the hemodynamics have to maintain. For example, if you have the left coronary, always keep a noradrenaline. And one important thing which we have to realize is that when you're doing a right coronary, we have a little bit of hypotension. Even if you don't have hypotension, but a bradycardia, keep an adrenaline infusion going. This prevents slow flow. And the intracoronary Nicoran is useful. Avoid multiple puffs. Intracoronary 90% sometimes is required when you think but then the hemodynamics should be okay there. Or if the hemodynamics is low, you have a hypotension, you use intracoronary adrenaline, which works wonders, and you get excellent results. But of course, mostly you may have to resort to intracoronary lytics or tirafiban. Sometimes at the end of that, you just take a small balloon to the tip of the stent, and then low pressure, you find the whole thing gets opened up and does very well. So this is again an algorithm for want of time, and I'm not going to it. And the most important thing, don't forget about the medicines, aspirin, clopidogrel. You have all the newer molecules. But one area of interest which I wanted to share is intracoronary lysis, where we have had large experience. For example, huge thrombus burden, even in stent thrombosis. In fact, sometimes I use even as an adjunctive when I have done a primary angioplasty. We have had a publication in Indian Heart Journal. In fact, many people you hear is a patient with a thrombus left main into the circumflex. So what we do here is that we take to calculate the dose of tenecteplase based on the body weight, 0.5 mg per kg. 1/5 of the dose we give intracoronary. Take a check angio 5-10 minutes later. You find that the flow is improving. Rest is given IV. And then this is what it looks like. You don't need a stent. So this has been really rewarding in many cases. In fact, we have now done hundreds of cases with that. This patient actually, poor man who could not even afford, LED is not visible. He was given intracoronary streptokinase, and you see the results, and he did very well. Sometimes, what happens is that, this is a patient who came with an young fellow. Within 4 or 5 hours, you find that there is a thrombus, LED is occluded, intracoronary lytics was given, and now you see it's a freely through flow, and now a crossover stenting from the left main to LED becomes a simple procedure, and then with excellent outcome. Again, same thing, infraposterior MI, you find that circumflex is not filling with them, and then you administer the lytic therapy, you find now it's opening up. Now the distal vessel is seen very well. And now you can choose your appropriate stent, do a stenting, and that actually translates into clinical benefit. So we have had a series of cases published. The only worry that is these patients might throw a VT and VF sometimes. Another patient during the COVID time, extensive anterior wall MI, you can see, came in the middle of the night, acute LV, a very sick guy, pulmonary edema. And then right is fairly good. That is an idea that the left will also be like that. But when you saw the left shoot, it's horrifying. Huge thrombus in the left main, LED is not visualized. And here, I again had no doubt in my mind. So administered immediately after 5 minutes of intracoronary first bolus is what you see there. So encouraged by that, the second bolus was given, and subsequently the entire this thing was given IV. And then 4 hours later, that's what it is. And he did very well. In fact, he is now 2 years post-testing, absolutely normal LV and doing extremely well with the serial ECG settling down in a short while. We have also used this in stent thrombosis. I just wanted to share a couple of cases here. Very late, 18 years after the angioplasty, people might think it's a re-occlusion. So came with an inferior wall MI while in the hospital, and that was what his RCA was. So we opened up with the balloon, not much of help there. And then what we did was, we used the first bolus, encouraging, you see, still says thrombus in the distal RCA. And then use the second bolus. This is in a stent thrombosis, we tend to use one more bolus. And then extensive bolus, heparin infusion, and then at the end of the day, at the end of the infusion, this is what the vessel is like. So I think this is very rewarding. Sometimes when you have a stent thrombus, I was away for a meeting. This patient came with an inferior wall. My colleague of mine put in 4 stents in the RCA from proximal distal RCA, was on tirofiban. LV ejection was okay. Day 2 stent thrombus, and that is what it was in the midnight. So he had to be brought back to the lab. He did multiple dilatations. Nothing helped. Patient was very sick on all supports. And then that is the time when I got a phone call, told him about this intracoronary lytic, and that was given. But in a stent thrombus, you may have to do a post-dilatation also along with that. And finally, at the end of the complete lysis, 4 hours later, this is what this thing is like. 4 years down the line, he is doing extremely well, climbed Shabrimala hills. He's just on dual antiplatelets, nothing else. So following an angioplasty, sometimes, you get a slow flow, which I had mentioned earlier. In that context also, where we used a streptokinase, slow flow after that, and that's what the artery looks like. But sometimes all said and done, you've done a good procedure. You expect the unexpected after PAMI. This is a guy who came with an anterior wall MI, LV down, going in for LVF. He had a left main plus an ostial circumflex. So I took him up, switched out to femoral, did a stenting from the left main to LED, and of course a provisional stenting, and then kissing balloon. That was what it was. We were very happy. Everything settled down. But in the middle of the night, he again, that was a result at the end of the procedure. But in the middle of the night, he again had a chest pain, and he went in for complete heart block. I thought that this man at 2:30 developed, the left main must be occluded. Anyway, with a shot of atropine, he improved. Asked him to take him back to the lab. He was taken back to the lab. He arrested asystole there. Put in a temporary first check shot, shows that the patent, stent is patent, everything is fine, the circ is flowing well. Why did this happen? So anyway, he was so sick, he had to be ventilated. He was on an IABP. But then we realized that this man was on a drug called Brilinta, ticagrelor. So this sometimes can produce these events. It's reported very rare, but we have seen this. He was stopped. He's 4 years now post angioplasty, is doing extremely well. So the PAMI, there are a lot of lessons learned. Most rewarding, challenging, variable presentation. It's important that you assess the patient. I will not take a patient to the lab without a screening echo, rule out a ventricular septal rupture or a pericardial effusion. We have saved lives that way because some of them have subacute ruptures. You never know. Targeted examination, anterior wall MI, wait for some time if they're in shock. Get an ABG. If the ABG is less than, the gas is less than, PO2 less than 7.1, think twice before taking them. Low threshold for intubation. I would always take them, intubate, and then put in a neckline, put them on acid inotropes, and then take. In Florida LVF, when the patient is very sick, I am a great fan of tenecteplase, like what that patient had a left main thrombus. Pharmacoinvasive works very well. You can always do a safe procedure. I think safety is the key when you do a primary angioplasty. And sometimes when you have all this, you in the lab, you will have a recurrent VTVF. People will push in Silocord, amiodarone. But one drug which will use useful is intravenous beta block, which will immediately arrest the VT, and then you can save many lives. So these are the lessons learned out of it. In fact, we have had extensive experience of primary angioplasty. We have developed a fast tracking. This is over the last 10 years. We have done more than 4,000 primary angioplasties now. And then the door to balloon time, though it's recommended to be, in fact, when we teamed with the Northwestern University, it's close to 22 minutes. And we are in many quality assessment registries. In fact, I am one of the members of the global heart attack trial, which is across 19 countries. I am from India. I am representing India. And then from 2020 onwards, we were there. So we have closely about 500 cases we have done, and our mortality remains as 15 deaths out of the 500 angioplasties. So I think this is a great way ahead. So knowing all these things and tricks are definitely helpful in saving many lives. And primary angioplasty is a welcoming and rewarding procedure. Thank you all for the kind attention.
Hello.
Hello, yeah.
Thank you very much for wonderful presentation, sir. Jayagopal, sir.
Thank you.
Yeah. First case, that the anomalous RCA was there. Your choice of catheter is AL1 is correct from radial approach. And after that, you have tried EBU3 curve? Or
Everything. You name all the catheters. I tried every catheter, everything that has been tried out all over the world. So this was one case where, this was innovative. I thought the Tiger catheter from the femoral root was very helpful. And that gave me an excellent support.
Okay. You have tried the EBU3 also.
EBU is my first choice in this thing. I always take it because I'm very comfortable with EBU. I mean, mostly even in a procedure, whether right also you can hook with an EBU, left you can hook.
Both you can do in one single catheter.
Yeah. Yes.
You can push it also. You can inflate the balloon and take anchor the catheter also.
So all these things have been tried, but these are, in fact, we have a large series of anomalous coronaries now. So, as you rightly said, my first choice is always an EBU because EBU, by and large, is very helpful. But this is one of case where this took me about 20 minutes to hook the RCA.
Yeah. One more thing, in the slow flow during after in PAMI and all, sometimes after post dilatation, vessel with slow flow and no flow will be there. At that time, if you can give a cocktail like eptipeptide, sodium nitropeside, and dirgem, all three mixed with one into the coronary artery directly with a cut balloon. Is it helpful?
Well, see, by and large, I think the most important thing, my first step is to prevent a slow flow. So, aggressive post dilatation is what really brings in. So if you're done a post dilatation, if you have a slow flow, the first thing I would always push in is a nicorine because it has not much effect on the hemodynamics. And if the hemodynamics, I'm not a great fan of tirofiban any of the glycoprotein 2B cocktail because it really does not work immediately. The only thing is that if it doesn't work, my second choice is always a nitropeside, provided the pressures are above 100. If it is not so, if the pressures are 50, 60, I would straight away push in adrenaline. And that works wonders. And the next important thing which I've seen is if a patient can afford, nothing like a tenecteplase, see intracoronary. In fact, it's much faster. 5-10 minutes, you will see the results. In fact, some of the technicians who have worked with me, moment they see one, they will say this is a case for a tenecteplase. So I think it's such a rewarding thing, but unfortunately, the cost is a prohibitive factor. But streptokinase, the problem is that you will have a lot of brady, arrhythmias, hypotension. So I don't prefer streptokinase as far as possible, but this is my choice. And sometimes, as you rightly said, dilsam might be helpful, but nicorine is the first choice. Second is nitropeside. Third is intracoronary lytics.
Okay, thank you, sir. Thank you very much. I will hand over the mic to the.
Thank you so much, sir, for such a wonderful presentation. And as you rightly said, saving a patient in PAMI is the best and the most rewarding thing for a cardiologist and the technologist in a team. Sir, you said about streptokinase. It is a little acidic, and that is the reason you have more brady, more arrhythmias and things. But if at all you have, because the good part about streptokinase, you don't have to explain it to the relative. You can take the decision on table. For tenecteplase, for
Absolutely.
the cost, you may have to send someone outside to explain it to the relative. So what dose
Yeah.
of streptokinase, sir, will you use? Because that
Yeah, so that's a good question. So what I generally do is, 1/5 is what we tried. In fact, we have now developed a protocol which is accepted. I think many people in the country now have accepted. There's a lot of phone calls I get every other day. So the tenecteplase is what we've seen with 1/5. So this has been extrapolated into streptokinase. So I give 3 lakhs, 15 lakhs, and 3 lakhs I use it. And then I don't really try to use the entire this thing of streptokinase until and unless there is a huge thrombus load. In fact, I had one patient where my cardiologist colleague put in a stent in an ectatic vessel, and there is a proximal huge thrombus. There, the patient could not, as you rightly said, you don't have to speak to them. So intracoronary was given, the rest is compared, and I did a check angio a year later, which is fantastic. So it works. As you rightly said, in fact, the days when streptokinase was marketed, the late 80s and the first, when I was doing my post graduation, the early 90s. So that time we used to call it the SK drama because you sign all these arrhythmias. And then we realized the one way to get over this is a shot of steroid. So if you really encounter an arrhythmia or a brady, you can use a shot of steroid and that overcomes. So you still don't have to worry about using this, but 3 lakhs is what I use.
Sir, like you developed like affines to tenecteplase, I in a short span of practice, magnesium sulfate helps in lot of arrhythmias. So when I take my patients for primary, I give MgSO for 2 gram, and usually in the initial part of the procedure as well, if there are those VPCs or something like that. Any role
No,
in that,
I
or
think
that's
the
just
first
a
important thing,
placebo
yeah,
benefit?
I know people using it, but then we have a large scale data showing that it's not very, I mean, it's not very promising. The randomized trials have been done earlier also. So the only other thing which people have forgotten, in fact, I started my career prior to the intervention arena. In fact, when we were seeing myocardial infarction, the first intervention I learned was Miami, metoprolol acute myocardial infarction, Miami trial it was. So every MI, irrespective of the thing, was given intravenous metoprolol. And we used to see the benefit of that. The arrhythmia is coming down, even if you are not lysing. I'm talking about the pre-lytic era. I'm not talking about the. So this thing, I think you still have to believe this. I have had patients with recurrent VT, VF, all this arrhythmia. If you have the, I think intravenous beta lock is a very good addition in the cath lab. You don't have to be scared about it. You don't give the full 5 or 15 milligram, even 1 milligram, 2 milligram based on their pulse rate and BP will do wonders. And I think that's saved many lives. I think this is something which people should also follow in the years to come.
Thank you so much, sir.
Hello. Sir, I have a question. Sir, last patient left main bifurcation stenting, you said the patient has taken for reshoot. What was the reaction with the ticagrelor? What was it?
Yeah, it was actually ticagrelor very well known to produce sinus pauses and heart blocks. In fact, there are about 7 cases reported in literature. About even 3 of them needing temporary pacemaker. But the first I learned about this was about when the days when this got introduced in 2014. One of my patients came with a sinus pause. This is known in about 3%. But complete heart block and a catastrophe like this asystole is very rare. In fact, recently there was one case from Trivandrum. So these are all extremely rare. And all that I did was switched over to clopidogrel. And he is 4 years down the line. His treadmill is negative. He's doing very well. His stent is patent. So it was actually a ticagrelor induced. These are things which you need to pick up in your. So it's just not doing the procedure, but I think the constant follow up is also that's a message I wanted to convey. All the newer drugs, newer stents, newer devices have their good part, but I think we also should realize the negative things about it and we should be open to this.
Because actually we also had a same kind of situation. We after the stenting, patient was there in front of us in PACU because ICU bed was not there, and patient was suddenly collapsed, and then IBP and intubation, everything happened there, and ECG changes were not much there actually.
Yeah, in fact, sometimes you find a profound bradycardia. So I am today convinced that when somebody comes with a profound bradycardia, inferior wall, I mean, ultimately it's your procedure which saves the patient. I think if you do a good procedure, timely this thing, and don't overdo the procedure, that's also very important. Then I think that's the key. Your medications are only add-on, and then you should be having an open mind as to. My majority of patients still are on clopidogrel. I must confess that.
And so sorry, actually this is not the question for you. Maybe senior technician from your side can answer this. You said door to balloon time you are trying to manage it below 22 minutes. But for our corporate hospital or the private hospital where the ratio of 3 is to 1 cath lab technicians, so it's really difficult to get managing the routine cases and again coming back for the. Do you have a 24 hours coverage of cath lab
Yes.
staff, nursing, everybody, and
Yes. Yes.
radiologists are
Yes.
just
Yes.
good to know.
So my staff, they're all staying close by. In fact, the moment an MI patient is a VIP in my hospital, it doesn't go to the casualty, it goes straight away to the cath lab. And fortunately, we have a good communication coming from the periphery. They tell you that there's an inferior wall or an anterior, and then it's taken up. But the only problem over the COVID as was a big this thing. This was a pre-COVID data. Now I think it must have gone up. This is actually when we got it published by the Northwestern University. But then after the COVID, there's been a problem because we were scared trying to get your antigen and all that took a lot of time. But now I think it's back again. So we tell them don't waste time on an X-ray. Just get an ECG, take them up. Bedside echo. In fact, my cath lab technician, I have told them they should be doing an echo, pre and post, and then that's how it is. And today, I think I'm sure everybody puts in a sheath within no time. So the radial sheath is a very simple procedure to do. So I think it is. So you can really bring down the delay. But the only problem is if you have a larger hospital. Mine is a very small hospital where the entry into the hospital into the cath lab is not very difficult. It's as easy as that.
Thank you, sir. Thank you very much.
Thank you. And next topic is safe usage of contrast media in cath lab, and this will be performed by Dr. Priyank Modi, and he's already on the stage. Inviting Dr. Priyank Modi onto the podium, please. And big round of applause, please, dear all.
A very good morning to all of you. I'm really happy that so many people have come on the final day of the conference. To be frank, 8 years before was one of the times when I came to Cochin only. It was the same conference, SPCIT was in Marriott, and my first lecture was there. So that was my actual first lecture as a national faculty. So here I am in debt to you, then you to me. Uh, Contrast media. Now, I have always been given the most basic lectures because I believe that once the conference is over, at least the basics should go right. So my previous lecture with the meet were on ECGs, and this time it was contrast media. Now, contrast media is something which is going to be required for any procedure you are going to do in the cath lab. So how did contrast media evolve? So even as of now, you see a lot of patients who would get an allergic reaction, sometimes shivering, sometimes a little bit of rash. And this is when overall we use low molecular weight contrast media or isoosmolar contrast media. So consider that now locum, or that is low osmolar contrast media, was introduced in 1985. So consider before that when they were using HCM, like high osmolar contrast media, what would have been the reactions the patient used to feel. So the previous, way back in 1950s, high osmolar contrast medias were used. Over the period of time, low osmolar, and now we even have isoosmolar contrast medium. Properties of an ideal contrast medium is like properties of an ideal spouse. Whether you go for your ideal wife or ideal husband, it only exists on paper and no one has been able to meet it till now. So ideal contrast media, it has to be water soluble, it should be chemical and heat stable so that you can keep it at room temperature on your shelf. It should not deteriorate over the period of time. It should be biologically inert so that when it enters your body, it does not give any kind of reaction. Low viscosity, so low reactions, and lower or same osmolarity as human blood. It should be selectively excreted through the kidney so that you can actually titrate how things should be. It should be safe, and the most important, it should be low cost, because we want everything which is good, but we want everything at a lower cost. Then only it makes sense in India. So now, why contrast media is important, and why do we actually require contrast media? So let us consider the example of a coronary angiography. So when we do a coronary angiography, what we are doing is we are taking a negative shadow of our coronary tree. Now, why do I say negative shadow? Because here you are not actually seeing the blockage. What you are seeing is the negative shadow the blockage creates in when you take a shoot. So when you say this is 80% stenosis, you are not seeing the 80% stenosis, but you are seeing the 20% residual flow which is going into your coronaries, and then you contemplate, okay, this is around 80% stenosis. So how does that happen is, all your cath lab machines, you see the X-ray is released by the emitter and the tube takes it. So you need a molecule which would break that flow of X-ray, and that will create a negative shadow, and different tissues of your body would have different penetration power, and that will create a different shadow based on like white, gray, black on that context. So iodine blocks the X-ray more effectively, and there are multiple, like some contrast which is used orally are barium. So but you cannot give barium intravenous because that would cause a severe allergic reaction. So iodine is the natural constituent of your body, and it would block your X-ray as efficiently as lead. And it is the most non-toxic thing you can give inside the body. And that is the reason over the period of time, iodine was the most common thing used in contrast media. Now, one has to understand iodine itself is biologically inactive. So whenever a patient of yours would develop a reaction, say itching or rash, then you would say he is iodine hypersensitive, but that is not the case. Patients are inert to iodine. These are different other materials which is present in your contrast media where the patient would be allergic to. Now, what are the common procedures where you require contrast media? To be frank, any procedure which is going to happen in your cath lab, you would require contrast media. There was an EP guy who spoke up in the last conference that we don't use contrast, but I use contrast for the venogram to take the puncture. So any procedure in your cath lab, you are going to require contrast, and that is the reason I'm not going to go. So here I would put up a disclaimer because this is my first slide as G. So contrast is the paracetamol of your cath lab, and G is the dolo of that paracetamol. Now, why do I say that? Because the most important reason why we change contrast is the cost. But when you consider the overall cost of a procedure, the cost of contrast is less than 1%. And the problems that can create by using a wrong contrast can sometimes be detrimental. And that is the reason it is always better to stick to quality here. So now it is an accepted fact that if you are going to work in a cath lab, you will have to use contrast medium for your procedures. So what are those three most important things you will take care when you are going to use contrast medium so that you can prevent the complication? The best thing, I would always say that the technologist is the quality controller of the cath lab. So what kind of quality is given in that cath lab is solely determined by who the technologist is. So by reducing the complications of any procedure or any drug used, we have to be well aware so that we can prevent it, and that is the best way forward. So allergic reaction to a contrast medium, very common. Abnormal heartbeats, arrhythmias. If you are using some other contrast which are not standard, say not Omnipac or Visipac or Ultravis, something else, then many times you see that when you give a contrast, there will be bradycardia on the ECG, because these are hyperosmolar contrast, and they would reduce the blood flow to the coronaries at that point of time. You have to understand when you are giving contrast at that 10 seconds or 2-second window, there is no blood flow in the coronary because your contrast is replacing blood, and that is where you have to be a little cautious. So three most important things are allergic reaction to the contrast medium, abnormal heartbeats, and kidney injury from the contrast medium, which is the most important, and what we call it as contrast induced nephropathy or contrast induced kidney damage, and that is something we'll cover in detail today. So allergic and non-allergic reaction to contrast, adverse reactions can follow use of iodinated contrast medium. They are usually rare and they usually occur in the first 60 minutes of injection. The most severe would happen in 30 minutes. So after 60 minutes, if it is happening, then usually it is not allergic drug reaction. And that is the reason many cath labs in today's era, you would like to keep the patient 60 minutes in the recovery room after your angiography is over or after your angioplasty is over, so that if you have something, it happens now. Chills and rigors are the most common things. Now, most of us technologists, we believe that it happens due to the ox material we use in the cath lab, but a proper ETO ox material would cause far less chills and rigors than a bad contrast would do. And lot of cath labs over the country, when they take a patient for procedure, you give 100 milligram hydrocortisone or say 2 cc of avil before you take the patient on cath lab. But again, you are adding the cost of antibiotic, avil, hydrocortisone, and then you are saving on the contrast media, which doesn't make sense. Late adverse reaction can also occur, but most of them, they are self-limiting. So patient may develop a little red rash after 5-6 hours when you go on a round to the patient, but most of them, they just recover and they do not require any form of medication. So now a lot of information here, but 2-3 important aspects, like all your contrast media would come with a package warning, like as sir rightly said in the last thing. Important aspect when you use a new thing or a routine thing is you know the effects of the drug, but you should well aware of the side effects of the drug, then only it makes sense, because effects of the drugs are available on Google as well, and side effects are also available, but then you need to know what is important. So just 2-3 important aspects here. When you store your contrast media, you store it at a dry shelf. Make sure that it is not exposed to sunlight, and you can keep it at room temperature. No need to put it in a refrigerator or something. Whenever you are opening up a contrast medium, you should discard the thing which is remaining. Even if you are reusing, like if you are using a large contrast like 100 cc contrast for 2 or 3 procedures, make sure you do not exceed the day, like whatever it is, uh, throw it over. And the ideal temperature to store your contrast media is 37 degrees, so that is your ambient temperature, and that can be well kept in your cath lab. So if your patient has an allergic reaction to contrast media, the first thing you would do is give 100 cc of hydrocortisone. Why do I say that? Because that is the fastest acting. And uh, 2 cc of antihistaminic drug, the most commonly available in your cath lab is Avil. Now, if at all, this you would do when your patient would develop a rash or chills or rigors. What if your patient develops a little bit of desaturation or the patient has heavy breathing? So this is now going towards anaphylactic shock. Now that is a severe variety of allergic reaction, and these patients should be given adrenaline. So start with oxygen. One very common thing what I do in my cath lab is, in my technicians and my sisters or brothers are very averse of giving IV adrenaline, but that is the best shot forward. So till they prepare it, break a ampoule of adrenaline and give it in nebulization to the patient, because that will reduce the edema of the larynx, and that will be uh, far more effective. So you can give small dose of oxygen, atropine if there is bradycardia. IV adrenaline is the best way forward, 1:1,000 dilution. If the patient has significant rigors or something which does not get relieved with uh, hydrocortisone or antihistaminics, then a small dose of sedative, that is diazepam or midazolam, can be given. The most important and preventable complication of contrast use is contrast induced nephropathy, because if you are going to use contrast and you have a higher creatinine, then that patient is going to have a problem. So what is contrast induced nephropathy? It is defined as increase in serum creatinine by 0.5 and or 25% above baseline within 48 to 72 hours. Now it varies widely from 0 to 50%. So if your patient is 60, 70 or 80-year person who has EGFR of 60, then his chances of contrast-induced nephropathy is far more than an 18-year young person who with normal creatinine you are taking. So the definition is rise in serum creatinine by 0.5 or 25% of baseline at 48 hours. Now, what is the normal trend when you are looking for contrast-induced nephropathy? That it would start by 1 to 2 days. So if you are doing your serum creatinine in the same evening, or you have done a procedure late night and then you are doing your serum creatinine the next day morning, you are not going to be able to diagnose it. So it starts by 1 to 2 days. If the creatinine is increasing but the patient is maintaining normal urine output, then you just wait. You tell the relatives that it is going to peak at about 3 to 5 days and it would come back to normal by 7 days. So once the peaking has happened, your creatinine will go from 1.5 to 2 to 3 to 3.2 and then again to 3. So that peak has already got over. Even then you can discharge your patient at 3 creatinine, because over next 5-7 days the creatinine will come back to normal. So ideal time to do a creatinine post contrast is 24 hours. Why contrast-induced nephropathy is important? Because it will delay your discharge of patient. Sometimes the patient may have a permanent kidney damage, he may require dialysis, and that overall increases the mortality. Now, you have done a primary angioplasty very well. You have opened up the artery, you have achieved a good TIMI flow, and the patient next day goes in acute kidney injury, and then cardiogenic shock, and the pressures don't come up and you lose the patient. Trust me, they are going to blame you for the procedure, not contrast-induced nephropathy. So in primary angioplasties, and be very aware, like as technologists, you should keep on reminding the cardiologist how much contrast is used. He should not get carried away, because for seeing, I have seen good senior cardiologists doing 5 or 6 shoots just to make sure that the stent is well opposed, to tell their own self that I have done such a wonderful job. So pathogenesis, oxidative stress, vasoconstriction, and direct tubular toxicity are the 3 main reasons why contrast-induced AKI can happen. Pathophysiology of contrast-induced nephropathy: intrarenal vasoconstriction, rheologic effects. It would affect how the blood or the RBCs flow into the renal system. Osmotic load, generation of reactive oxygen species, and direct cytotoxicity. All of this would cause medullary hypoxia and contrast-induced nephropathy. Diabetic patients are the most predominant patients who would develop CIN, and you should always be aware when you have a diabetic patient coming to the cath lab. So risk factors: patient already has a higher creatinine, he has diabetic nephropathy, he has more age more than 75, he's already volume depleted, whether it is CCF or chronic liver disease or dehydration, or patient has hypotension when you start the procedure. If he's taking other nephrotoxic drugs, like some old patient who's taking NSAIDs, NSAIDs for knee pain, and then he has an MI and he comes to you. So these are the patients who are going to have more chances of contrast-induced nephropathy. So I will just suggest you 2 simple calculations, because these are important. I always believe that as technologists, you should be aware of what are the chances of contrast-induced nephropathy, so that you can tell your cardiologist where to stop. Procedure-related factors: what are the type of contrast agents you use? Now, most of the people, we use low osmolar contrast or isoosmolar contrast. What is the dose of contrast used? If you are repeating a procedure, because I have seen this one very common thing, you do a CT coronary angio and after 1 day, 24 hours, you take the patient for conventional angio. So when you are repeating the dose of contrast medium within 72 hours, it's not a good thing. intraarterial radio contrast will harm more than intravenous. So your coronary work is intraarterial, so there the contrast would harm more. And primary coronary intervention for acute MI is a risk factor for CIN, and you should always limit the contrast used. What is the risk assessment? You tried the patient as low, intermediate, and high risk, predict the CIN, individualize, and start the preventive procedure based on your strategy. So these are two risk factors. This is a more comprehensive risk factor that is called as Meridien CIN risk score. This is easily available on Google. You just have to download the app. You have to just put in the details and it will give you a risk stratification. So hypertension, use of IBP, congestive heart failure, age greater than 75 years, anemia, diabetes, contrast medium volume, and what is the baseline creatinine. You can calculate the risk. If the score is more than 16, 50% of the patient will develop contrast-induced nephropathy, and around 10% will require dialysis. So this is easily available online as a calculator score, and you just have to put in the details. It will give you the score and the risk. Rather, if you are in a big corporate hospital, you should develop this as a practice, because this will be even good for medico-legal purpose. Because if you are giving a scoring before you take the patient on table, later on if the patient develops CIN, you can always have a discussion. Now, simple thing which you can calculate in your cath lab is ACF score, or a newer version is AGF score. So this is age, serum creatinine, and ejection fraction. These three things every technologist knows when you take the patient on table. So age divided by ejection fraction plus you add 1 if the serum creatinine is more than 2. If the score is less than 1.48, then your patient will not develop contrast-induced nephropathy and you can safely do the procedure. You need not give hydration or anything. If your score is more than 1.5, then you should give preventive strategies. So similar to ACF score, the more comprehensive is AGF score, where you use glomerular filtration rate. Now in my setup, I have told the pathologist that apart from serum creatinine, they will always mention EGFR on the report. In most of the hospitals, that is not available, but if that is available, it is a more comprehensive thing. So the equation remains the same. It is age divided by ejection fraction, and you add 1 if the EGFR is less than 60. As we said, EGFR is better representation of kidney status as compared to serum creatinine, because it includes the age and sex of the patient. So if you have that, AGF score would be better than ACF score. Now, by now I know what are the chances that my patient will develop contrast-induced nephropathy. So how am I going to prevent it? So these are some myths which are available in the cath lab, and I think we should consider removing them. So the thing is, minimize the volume of contrast medium. The chances of contrast-induced nephropathy does not depend upon the absolute amount of dye, but depends upon the relative amount of dye which is good for that patient. As I explained, if an 18-year-old boy is there and you are doing a procedure, you use 300 ml of dye, nothing will happen. But if for a 70-year-old patient who is diabetic, if you are using 100 ml of dye, then also it will cause CIN. The chances of contrast-induced nephropathy does not depend upon the length of the procedure and number of stents. There would be a cardiologist who would complete the procedure in 30 minutes and then take 30 shoots in that 30 minutes. Does not make sense. So length of the procedure, number of stents does not determine. You do the procedure, that is where IVUS has a role. Like when you take multiple runs of IVUS, that gives you information that will increase the length of the procedure, but it will reduce the use of dye. Direct correlation with elective use of IBP. If you have used IBP, the chances of CIN increases, because if you know your balloon would be just above the renal arteries, and each time your balloon is going to inflate and deflate, it is going to send small atherosclerotic particles from the aorta to your renal arteries. The most important correlation is with TME3 flow. So if you have achieved a good TME3 flow at the end of the procedure, it will overall improve your cardiac function and reduce the chances of contrast-induced nephropathy. So what is in the hand of a cardiologist to reduce the dye usage and achieve TME3 flow? And what is in the hand of a technologist, yet that your cardiologist follows these two things. Do not let him go away from the table if TB3 has not been achieved, and make sure he does not increase the diode. So what is the dosage of iodinated contrast which is maximum? So phi into body weight divided by serum creatinine. So you just have to calculate if your uh, patient is 60 kilos, so phi into 60 is 300, and if your creatinine is 1, then you can use around 300. If your creatinine is 2, and for a 60-year-old, then you should make sure that you do not exceed 160, because once you exceed this maximum acceptable contrast dosage, the chances of developing CIN exceeds 50%. The another thing is less case formula, that is 3.7, or you can use 4 into EGFR. So if your EGFR is 60 multiplied by 4. So this is maximum tolerated. I would want every technologist to now start putting this on that uh, whiteboard which you have for the patient's name, his creatinine. So you should just put this value, that 150 ml, so that your cardiologist does not exceed that volume. How would you minimize the risk? You discontinue all the nephrotoxic drugs. Make sure that the patient drinks. We only need 2 hours of fasting for most of our awake procedures. So make sure that the patient drinks orally till the morning of the procedure. Even post-procedure, if the EF is on the normal side, you encourage the patient to drink more water. Do not repeat contrast for the next 72 hours. And if the chances of developing CIN is very high, apply a prevention protocol. So what is your prevention protocol? Hydration. Hydration is the most important thing. Now, there are two regimens which people use. There are a lot of people who use 0.45 normal saline, and then there are people who use 0.9% normal saline. That is your regular normal saline. So when you start IV crystalloids 1 ml per kg per hour, start before 12 hours and continue after 6 hours of your procedure. So 1 ml per kg per hour, start before 12 hours and continue for 6 hours, 12 hours, 24 hours, depending upon what your creatinine is. So 1 ml per kg per hour is 60 kilo person, 60 ml per hour. If your patient's ejection fraction is on the lower side, so less than 40, you can reduce it to 0.5 ml per kg per hour. The data for 0.9% normal saline is better as compared to 0.45% normal saline, because the mechanism thought is it would increase the delivery of sodium to the distal nephron, and that would reduce the activation of RAS. And it will increase intravascular volume better, and that will cause reduction of renal production of nitric oxide. So if you want to use a fluid, then 0.9% or your normal saline would be the best fluid forward. There are data about sodium bicarbonate. Okay. So no evidence for sodium bicarbonate or mucomix or N-acetylcysteine, what we usually use. But if you want to use, it is 3 ml per kg per hour, 1 hour before procedure, just before you are going to shift the patient, and you can repeat it after 6 hours. And IV mucomix is, or N-acetylcysteine is 150 milligram per kg, or you can give an oral tablet of 600 milligram BD. So these are 3 preventive strategies which are used in routine practice. Thank you so much.
Sir, I want all the points are well explained. When in a patient with high level creatinine values, how do you control contrast usage? Whether you go with a IVS guided angioplasty?
So rather, we just had a discussion yesterday. I have just done a zero contrast angioplasty, which is now thing in vogue just last week before. The first thing, sir, is to use isoosmolar. Now, VCPEC is the only isoosmolar contrast medium available on planet. And why do I say that? Because we live in an era of medico-legal importance. So if the creatinine is high, if you have calculated that the chances of developing contrast-induced nephropathy is high, the data all over the world says that isoosmolar is the safest agent. So if you are using any other agent, if I am a layman who's an engineer by profession and who loves Google, and if I come to know that you have used any other agent, I would sue you. because if there is something more safer, then why not use that? So VCPEC is the only available isoosmolar contrast medium on planet Earth. So that is your only contrast medium. As you said, like, so zero contrast angioplasty is now a very easy thing because you just require IVUS. If you have IVUS, you now once you start using it, your requirement of angio dye is very less. So this last case what we did was a patient who had creatinine of 4.2. He was a UK citizen and was not on dialysis. So if I'm going to use contrast, he is 100% going to require dialysis in future, and that is a big thing, because if your patient is already on dialysis, it is simpler that after procedure he goes for dialysis. But if he is not, you have to preserve that. So angiography was done outside. It was a heavily calcified. So we used the Rota Pro. It was a diffusely diseased LAD. We used distal LAD was just drug-eluting balloon proximal 38 3 into 38 stent was put, and in the whole procedure only at the end of the procedure 2 ml of dye was used in a cranial view to make sure that everything is okay. Your first run of IVUS would give you information about what is the type of lesion. So based on that, whether it is fibrous, calcified, you take a call on whether you are going to use rotablation or cutting balloon or something like that. Then after your debulking strategies, you would know what is the size of your uh, artery and what is the landing zone. Now most of these give you an idea about the length of the lesion as well. So that would help you in the placement of stent. And after stent also, whether there is any distal head dissection or not, IVUS run would give. Post procedure optimization of the stent also can be done based on IVUS. So if you have time, if you have a stable patient where you do not have to worry about things, you just have to maintain proper hyperinization by ACT. You can lengthen the procedure for 2 hours, and practically you will not require contrast medium. So now it is seriously possible, and it is possible in most cath labs. Rather, doing rotablation is more difficult than doing zero contrast angioplasty, because you just have to rely on any imaging you have.
Thank you, sir. Any question from audience? It's a very important topic for technicians and staff.
Sir, as I said, you are very true, but if there is no flow, slow flow, you will have hemodynamic changes as well. And I have always take the final shoot. I am not saying that. And that is the reason zero contrast angioplasty is for stable patients, where the chances of no flow, slow flow are far less. And sir, when you are doing things under control, like this patient of us also developed ventricular tachycardia. So we had to shock the patient and take that 2 ml shoot in between to do that. So the flexibility of taking shoots with contrast is always there, but at least you can minimize it. And when you are using, sir, 10-15 ml of dye, even with 4.2 creatinine, trust me, it will not rise. So that is a decent thing. It's not an absolute thing. Patients' health is and safety is our most important priority, but it can reduce the overall usage of contrast.
Any thrombogenicity is there in ionic and low osmolar and isovascular?
Sir, like more the osmolarity, more thrombogenic it is, because it would activate your platelets and increase thrombin generation. So low osmolar and isoosmolar are pretty much same in terms of, no, they are reduced thrombogenic. Higher osmolar are more thrombogenic, sir, because higher platelet activation and more thrombin generation. So more the viscosity, the more like if you throw water from here, it will go faster. If you throw milk from here, it will go slower. If you throw honey from here, it will even go slower. So more amount of time the dye would spend in your coronary artery, more generation of thrombin. You just don't give it to your doctor. Because I have seen a senior technician saying no to AB meta sir, ke sir, now, tomorrow now we will do the next artery. Because your cardiologist would get carried away when things are going very good, or when the things are not going good. In both the cases, the cardiologist does not remember what is happening, and then that contrast keeps on happening. So maybe calculate the maximum permissible contrast when the cardiologist has used 70%, like this time buzz, that you have used 70% of your maximum tolerable thing. So you stop so that he can take his final shoots, do some post dilatation, and come out. So that is a better way forward.
Yeah.
Good morning, Dr. Priyank. Nice to see you. So actually, curriculum point of view, RCS, you must be aware that there is a setup of pharmacology also subject, concentration solute, which is you really pointed out a cath lab technician has to know, creatinine clearance. Other point I was saying medico-legal also, what you mentioned the last, which we I think have everything technician has to be now aware of. One more point was, I read in one of the New England Journal, whatever you said about isomolarity, and the density, viscosity way you explained, right? The honey and the other point was that Visipack, I read long time back, there was a research work, that it should be avoided during the angioplasty. Now still in my mind always is why it should happen. Could you, have you come across this?
The data, it is not about, because see, why I usually don't like saying the names of a thing, but that is the only available brand. So then there is no competition
Alternate
here.
competition.
So that is the only available brand all over the world, which is isoosmolar. The data for low osmolar and isoosmolar are pretty much same. So it is just if you are using low osmolar contrast, you are getting all the benefits as compared to a high osmolar. So there is very little extra benefit you are going to get from isoosmolar, because low osmolar works pretty much the same. And that is the reason there is no added benefit of using isoosmolar for each case of yours, because you are getting another thing which is 70% or 50% of the cost, and there is no added benefit, then makes no sense. But in a subset of patients where your creatinine is very high, like I said in my subset of patient where it was 4.2, so using something which harms the least is best. Now I do not remember any independent paper which says it should be used or it should not be used, but the theoretical data is very good. And as I said, these companies, because they have this monopoly, I don't think they would go for more research until they get something which is very, very low, which has come into market, and then they have to prove that, okay, mine is better or at least not worse.
Huh. That I checked with it, Eurographin, which is always used to be a taboo. The company told me they have really worked and improved on it. And it's much better to use Eurographin in angioplasty rather than any of these
I would rather not go for brands. I would say using low molecular, low osmolar for all your patients. High osmolar in today's era should not be used because it can cause problems. And sir, we have to understand, it is not just iodine we are using from a standard company. We are using the whole contrast. So it has multiple other ingredients, and that is where the quality standard should be maintained, because we should know what is inside. And the reactions also do not happen to iodine, it happens to the ingredients which is, and that is where a standard thing should be used.
One more idea was we were sharing when you said iodine and lead. Why not in the future iodine becomes a protein, you design in such a way that it becomes a protective and will be comfortable as a lead apron.
Visipex, yes, because anything which is, it is going to give you not as great shoots what we are going to see, but so there are some people like when I did not use Visipec, I used to you dilute your Omnipack with 20% saline, get that kind of so you are using lesser contrast. So ultimately the aim is lesser contrast, whichever it is. But if you are same, if you have a better machine which is going to give you more clearer image, then using Visipec makes sense. And for a routine patient, there is no data which supports that you should use isoosmolar as compared to low osmolar. Both are pretty much same. वो हमारे भाषा में 19-20 का फर्क है.
you,
One
doctor.
second, sir.
And please be on the stage to receive the memento from the moderators.
Sir, 1 second.
Yeah.
Yeah, please come. Thank you very much for a wonderful presentation, sir. This is a very important topic for us. And thank you.
Thank you, Dr. Priyank. And let's move on to the next presenter. I would like to invite Mr. Manoj Sharma onto the dais, please, to present about nightmares. He is from Sidus Hospital, Ahmedabad. Let's invite Manoj Sharma onto the stage, please. Big round of applause, everyone.
Hello, good morning, everyone. I am so glad to see you. So many of our colleagues are attending this technology international program to upgrade themselves in various aspects of cath lab procedures. I am also thankful to the ICVT organizers to give me this opportunity to share my experience. My topic today is cath lab nightmare. How did we manage? This is the history of the patient. 75 years old male patient, a known case of hypertension, and had a acute onset of chest pain associated with perspiration. Patient consulted with local hospital and ECG was suggestive of inferior posterior wall MI. Patient had VTVF and it was DC verted twice. Then with the inotropic support and the other medicines, patient was shifted to our hospital. He emergently underwent coronary angiography via the right radial artery through 6F radial sheath, which revealed proximal LCX and mid-LAD stenosis. Right system was normal. So for your information, this is the angiogram view for right coronary. Right coronary was not that large, but it was normal. This was the LAD lesion. It had some lesion, proximal critical lesion, but this was not the culprit vessel. Then we have treated this vessel in the stage PCI. This was the angiography view. You can see some proximal tight thrombotic stenosis in this aleocaudal view also. Looked very simple, this view. If you see this again, see, we thought that we will take a balloon and will dilate it. So we have taken 210 balloon, dilated on 12 pressure, and balloon was inflating 1 to 1. So we thought that the stent will take directly a stent. So we took a stent of 3 into 26. So what happened? The edges of the stent were opening. Shoulders are opening, and from the middle of the stent, it was not opening up. So we thought that there is a problem in the deflator. Normally we see in the cath lab that most of the time if the stent is not inflating or the balloon is not inflating, we always blame to the indeflator. So we thought that the indeflator should be changed. So we have changed the indeflator. Even then, when you see in this view, some contrast going towards the LAD area. You just see, yes, some contrast is going towards the LAD area, but we could not mark during the procedure. We thought that we are only focusing on the edges of the stent, why the stent is not opening up. But we don't know what is going wrong there. Now the stent balloon is not getting inflated even after changing the indeflator. So we thought that we should remove it, the stent. So what happened? Now the stent balloon is not getting inflated, not moving. Inflator got the blood into it. So we thought that the balloon is ruptured. So we should remove it out. While removing it out, the proximal stent struts were distorted. You can see. We have applied jerking force to remove the stent. You can see in this case, we have applied a jerking force to remove the stent. But because the stent edges were well opened and it was not coming out. So what to do next in this case when patient is with acute MI, the vessel is culprit, patient had a VTVF history and we have given shock twice. And in this case, we have done the mother in child support. We have taken this small catheter into a small catheter and we have gone very close to the stent because it was a proximal area of the vessel. So we could go through the guiding extension catheter and we have taken this stent. But stent was moving towards the radial area. Actually, we wanted to enter this wire through the stent so that we can trap this stent with the balloon. Then what we have done, because this was a culprit vessel, we could not waste time in just removing the stent. What we have done is, we have done the femoral puncture through 8F, we have gone through the femoral artery and we have done the angioplasty. So this was the optimum result we have achieved. Then after, what we have done is, one catheter was there already in the radial artery and the other catheter is coming from the femoral. We have put that catheter distal to the stent, proximal to the stent, so that the stent should not move beyond that. And we have taken the snare. This is LifeTech square snare. And through the snare, we have taken this stent. In the last frame, you see this stent will come into the guiding catheter. We trap the stent and we have taken into the guiding catheter. Now what happened? The stent was flared. Actually, stent was 3 mm and the guiding catheter was 8F. So it was flared, it was not coming into the guiding catheter. Still we thought that the vessel is so large there in that area, it will taken out. We have taken it out under the fluoroscopy guidance. We have removed it out. In vitro examination, leak in the shaft of the stent balloon only partially inflated and then not getting deflated or inflated further. We have the video taken which will show you now. After the procedure, what we have done, we have cut the shaft of the balloon. We have taken the small needle. Through small needle, we have pushed the saline. You can see the shaft is leaking there. And because of this leaking of the shaft, the balloon was not getting inflated. So all the pressure was transmitted from here and it was not inflating. So take-home message is unexpected manufacturing defect of US FDA approved stent can create cath lab nightmare. Mother in child catheter may give adequate support, prevent proximal vessel injury from distorted stent. Attention to the leak of dye from EBU into LAD should have alerted us to prevent further dilatation with indiflator. So if as a technician, we should have seen that the vessel, the LED vessel is filling through the dye, that some dye contrast is going towards the LED, means some shaft is leaking from there. Actually, we were always looking at the stent, whether the stent is inflating, why it is not inflating. But as a technician, this is a message that we should see all the way what is happening with the stent or what the other vessel says. We should not focus on the area where we are doing. The other vessel we should also see. Thank you so much.
thank you very much. It is a wonderful case. It will happen. See, it is a manufacturing defect. But you might have got little high inflation, maximum. At least it will open a little. After that, you can take say, another balloon, the smallest balloon.
Yes, sir. Our plan was
partially inflate. See, if there is any leak also, it will go inflate high 35 inflation. At least small portion of the balloon will inflate. Then you can pull back the balloon. Try with a small 2 mm balloon and you can dilate again.
Yes, sir. Actually, our plan was same, sir, what you said. At least a small amount of this tent, if it opens from the middle, then we can end, because a wire was already there. We wanted to go with one balloon or 1.25 balloon and then upsize the balloon.
That can be done.
And we should have just dilated. But actually, the balloon was not inflating and the blood has come into the indiflator.
Yeah, definitely. The small hole will be there in the shaft.
Yes.
What you have to do is don't rotate, push it directly. Indiflator, just push it. Partially, it will inflate.
Actually, sir, this dye which is going towards the LED, we could not mark during the procedure.
Yeah.
If you would have marked this dye going towards the LED, we may have gone like your strategy. But problem was that we have not seen the dye going towards the LED. That was the problem. So if we would have seen that the dye is going towards the LED and some shaft is leaking, so we would have gone on high pressure. Actually, we could not mark. But after the procedure, what I have done is I have just postmortem I've done the postmortem of the balloon. I've just cut the shaft of the balloon with 26 number of the needle. I have just injected the saline, and through saline we would come to know that there was a leaking in the balloon shaft.
Yeah, thank you. Well done. It's a very good case. So many times it happens. Sometimes it won't inflate. Sometimes we'll not remove the outer cover of this one. It will go. It will not inflate. Sometimes that happens. But wonderful case. You have managed nicely. Removed the stent also outside.
Hello.
Sometimes in radial artery pulling back, we can deploy there only.
Yes, sir.
Instead of pulling that one, trauma will be there. Radial artery is small. You can inflate there only and come back.
But because, sir, stent studs were distorted and it
definitely.
was
See, while pull back, it will trauma. It will dissect the artery.
Right, sir. Right.
Yeah, that's the problem. Okay, well done. Thank you. Thank you very
sir.
much.
Thank you.
Yes, I request the moderators to present the memento to Mr. Manoj Sharma.
It is a small request for the delegate, those who are not checked out. Those are not checked out. It is very essential to check out before 12 o'clock.
Our next presenter is Ms. Shweta Gaurav from D.Y. Patil Hospital, Mumbai, and she'll be presenting about MACPA blood closure. Let's invite Shweta with a huge round of applause. Thank you.
Good morning, everyone. I am Shweta Gurav. I am currently pursuing my third year in BSc Cardiac Technology from D.Y. Patil Hospital, Nerul, Navi, Mumbai. I am here to present you a case which was conducted in our hospital. Along with, and I will
Shweta,
give you.
one second, please. There's a request from the officials. There's a request to check out by 12 p.m. and that's the information given by hotel officials. You need to check out by 12 p.m. Thank you. Shweta, please carry on.
Okay. I am here to present you a case which was conducted in our hospital, along with giving a sort of information about it prior. The topic of my presentation is MAPCA in TOF. First, let's start understanding what MAPCA is. MAPCA, the full form of MAPCA is major aortopulmonary collateral arteries. As the name suggests, the MAPCA is an anomalous blood vessel which arises from the descending aorta and connects to the pulmonary artery. It helps in increasing blood supply to the lung. It usually arises from the anterior surface of ascending aorta and connects to the intrapulmonary arteries at the hilum of the lungs. The MAPCAs are usually present in cyanotic congenital heart defects like pulmonary atresia and tautology of Fallot. The presence of MAPCAs is one of the characteristic features of TOF. Let's now understand how MAPCA develops. During the early fetal stage, vascular plexus of vascular plexus of lung beds are connected with the segmental arteries. Later on, this lung receives blood from these segmental arteries and the sixth brachial plexus, which later on develops as a pulmonary artery. By nearly 15th day of gestation, this segmental artery regresses, and which leads to the patent connection of segmental arteries to the right ventricular and aorta. As developed lungs receive blood from pulmonary artery, but in this condition, the pulmonary arteries are hypoplastic and not well developed. Therefore, the lungs receive blood from these segmental arteries. We'll move forward to understand the type of MAPCAs. There are three types of MAPCAs: bronchial, direct aortic branch MAPCAs, and indirect aortic MAPCAs. Direct aortic branch MAPCAs, they arise from the aorta and the thoracic branches of aorta, where bronchial MAPCAs, they arise from the aorta and the thoracic branches of aorta, whereas the direct aortic branch MAPCAs, they originate from the descending aorta. Indirect aortic branch MAPCAs, they arise from descending aorta, abdominal aorta, subclavian aorta, and they distribute to the various part of the body according to their origin. Characterization of MAPCAs is done according to number, origin, course, and nature of supply. According to numbers, MAPCAs are characterized as single MAPCAs and multiple MAPCAs, whereas according to origin, MAPCAs are classified as MAPCAs are identified as left or right subclavian artery, transverse aorta, descending aorta MAPCAs, and abdominal aorta MAPCAs. According to course, the MAPCAs are characterized based on the insertion of a plug into a lung parenchyma. That is as if the MAPCA is entering into left pulmonary artery, into right pulmonary artery, or at the bilateral arteries. According to the nature of supply, MAPCAs are classified as single supply, isolated supply, dual supply, and mixed supplies. The treatment or the management of MAPCAs basically act as a palliative surgery even before the major surgery. The MAPCA treatments includes unifocalization and the device closure. Unifocalization includes focalization includes the blood vessels which are not directly or properly present in the body, but the procedure include rerouting of these various anomalous arteries into the single vessel, which are then attached to the single vessel, and then they are attached again to the right ventricle by the help of the homogeneous graft. Now we'll learn about the device closure. It acts as a palliative surgery. A vascular plug or a coil is inserted into the large MAPCA, which obstruct the blood flow through the systemic artery and help to reroute the blood flowing through the pulmonary arteries. Some of the catheter intervention which helps into management of TOF are as follows: balloon dilatation of pulmonary valve, balloon dilatation of block petition, stenting of RVOT, transcatheter pulmonary valve implantation for late post-operative pulmonary regurgitation may help. But the main thing which we are going to discuss now is MAPCA closure with the help of plug or a coil. We'll try to understand this with the help of a case which I am going to present it in front of you. This is the case history of the patient who was presented in our hospital. A 23-year-old male patient was presented with the history of rheumatic heart disease and a known case of TOF. The patient was advised for ECG and echo for evaluation, and the patient was posted for cardiac cath for further investigation. The ECG findings of patient were suggestive of tall R waves in V1 and which are monophasic, and sudden transition of R waves in V2, which were much shorter, which suggests right axis deviation. No Q waves in lateral leads suggesting decrease and there was no Q wave present in the lateral leads, which suggests the decreased pulmonary blood flow. The echocardiographic findings show large malignant subaortic VSD. The size of VSD was 1.5 centimeter with the bidirectional shunt. Further finding of echo showed right ventricular hypertrophy, dilated RA, and overriding of aorta. The cardiac cath procedure showed when the patient was posted for cardiac cath procedure, these were some of the shoots which were taken to confirm if the patient has TOF and for the other findings. This is one of the view. This is the aleocranial view, which showed large malignant subaortic VSD. The further shoot showed normal coronary arteries. The views are here. The views here are aleocaudal and epicranial. These views are taken by putting the pictal catheter in aortic root. For the further investigation, we did an RV angiogram, an epicranial view, and lateral views, which shows right ventricular outflow tract obstruction with the hypoplastic pulmonary valves. You can also see here the patient's pulmonary arteries were of confluence size. Aortogram in epicranial view showed large tortuous MAPCA. This type of MAPCA is direct aortic MAPCA, which we find here. The shoot was taken from D5 level. Here, we again went further and we properly engaged the catheter into the MAPCA and for the clear view of MAPCA. These are some of the findings of cath. The pressures are mentioned here. The aorta's pressure was 99/74 and the average was 85. The pressure of MAPCA was 100/60 by the average of 80. The right ventricular pressure was 80/24 and the right pulmonary artery pressure was normal. The findings in cath, as we can see, even by the echo findings, we got to know the patient had TOF. The patient had confluent pulmonary arteries. The patient's coronary artery was normal and the patient had major single MAPCA. The patient was further advised for MAPCA embolization and ICR. As the patient was posted for MAPCA embolization, we decided to embolize the MAPCA by using 12 mm Amplazer vascular plug 2. Here, in the first shoot, we tried crossing the wire and passing the catheter along the wire. In the second shoot, we just took check angio to pass the wire along with the catheter. Further, we again inserted the wire to just engage the catheter in the proper position, and in this position the entire procedure was carried on. In the next shoot, as you can see, we are here taking the plug and the plug will be inserted with the help of the delivery cable. The plug is getting released. Further, we took a check angio even before the releasing of the plug with the help of the delivery cable. After the check angio, the plug was released. After the releasing of plug, we again took the check angio, but the catheter was engaged in, it was actually engaged nearer to the plug to check how was the blood supply and the perfusion along around the MAPCA. Later we took the check angio while engaging the catheter in the aorta. Here you can see there is no further blood supply from the MAPCA. The successful transcatheter device closure of large tortuous MAPCA was performed. The post procedures, patient saturation was maintained and patient was hemodynamically stable. After the embolization of MAPCA, the patient was shifted to surgery OT for the further treatment of ICR. Thank you. May you have a nice day.
Thank you, Shweta. That's a wonderful presentation. Actually, we are running short of time, and it's actually it was really explanatory, and I don't think there are any questions, further questions.
Thank you.
You have done it extremely well.
Thank you.
Good luck.
Thank you, Shweta, and please be on the stage to receive the memento from the moderators for your magnificent presentation. Big round of applause to Shweta. Thank you, Shweta. Please take your seat and let's move on to the next topic, newer advances in cardiac cath lab applications. And in order to present this, let's invite onto the dais Mr. Anjani Kumar Yadav from Philips. Yes, big round of applause to Mr. Anjani Kumar, please.
By the way, my name is not Anjani Kumar Yadav. He's an MLA of our place. I'm Anjani Kumar just. So it is done. Is it done?
Those who have not checked out, please do it very soon.
Okay.
Yeah.
I should say good morning or, yeah. So before 7 minutes, right? Okay. Okay. Very good morning all. My dear friends and colleagues, representing Philips by showcasing the new advanced tools in cath lab. So before that, I just wanted to say that when I was a tech, I feel that I'm so proud of as a tech first. I worked as a cath lab technologist for 15 years in Apollo hospitals. That's been a great tenure for me to learn a lot in the cath labs. And one of the doctor has said me one thing was, if the cardiologist is a pilot in the cath lab, then the technology is a co-pilot. Definitely yes. Completely agree, right? Somebody said that he is a barnstormer. Barnstormer means that he should guide the technology. The technology should guide the cardiologist in the cath lab. What kind of a intervention need to be done? What the wire need to be done? What kind of a hardware need to be selected in the cath lab? The contrast module. Even yesterday, Dr. Ramesh has rightly mentioned in that saline OCT, right? He has said that in his case of saline OCT also, it was clearly mentioned that the technology is most important in the cath lab, that he could drive the cardiologist in the tougher times. So cardiologist is the pilot, means technology is a co-pilot. So that was my introduction. I just wanted to give that. And thanks for the opportunity for the entire team and who are sitting the jury here, Vijay Kumaran sir and as well as Pandey sir. Thank you so much for this. And thanks for Mohan also to give the time. Thanks for entire the people who are sitting here and giving the time for me. Thanks a lot. And we are in Philips has reinvented many things in the cath labs. It was not started in the cath lab first. It was been started in, Philips radios, Philips electronics. If now also many of the people, they will say Philips means lightning. So there is a light in my home. So which is still they will say that lightning. They will talk about, they will recognize with the light first. So light is never ending. Similarly, Philips also is not in a never ending process. It is a step ahead from all the competitors and in the market. So we are lightning. I can say that I'm proud to that. If somebody says that Philips is lightning company, yeah, I would like to say that we are. Because lightning will never stops and we are also going for a step ahead in the market. So thus we have started with lightning first, and we have done the interventions after the Second World War, and we have started with we have clubbing most of the things in the cath labs also before the cath labs. And in the we are consistent in the leadership. It could be for air perfumes, not only healthcare, we are in the diagnostics, prevention diagnostics, we are in the treatment, we are in the home care, everyone. So because not wanted to stop in one area, wanted to be in the entire the area, and we need to give an end-to-end solution to the patients in the cath lab or apart from the cath lab also. So Philips is pioneered in the image guided therapy, we will call it as IGT. In that 85, the first X-ray has been invented. In the 1958, the first diagnosis of cardiac. And in 1975, the Philips diagnostic seal, it was been intervened for the angiograms. In 81, it was the vascular system. In 87, it is the first 25 frames per second it has been started. 89, again the first sealing with the integrous, not with the flat detector. In 2001, it is again the flat detector. And in 2007, in between of 2001 and 17, many of the applications has been intervened in the market. So especially we said that, like I said that previously in the beginning, the light will never stop, there is no ending. Similarly, for the applications, also there is no end for that. In 17, we have started with a platform of many of the interventions, and 19, we got a flex arm in the cath lab for the hybrid cases, and many of the interventions that need to be done, because so now it is not only stopping, the cath lab is not only stopping with the cardiac things, we have been heading for the radiology, intervention radiology, vascular, now it is for lung also. In 2018 onwards, when corona has hit us in a very bad stage, now the lung has been introduced in the market, we are doing lung suits in the cath lab also now. And in 2021, we have reached a functional cath labs in India of 1,000 plus. In the market, we have a 60% market share in India, and globally also we have gotten a very good share. But we have 1,000 plus cath labs which are functioning cath labs in India at present now. And our aim to reach 2.5 billion people by 2030, along with the home care and all, along with that, many of the things what I showed you, that what we have intervened in the previous years. So now, after this, we wanted to reach 2.5 billion people with the healthcare, with the lightning, with many of the modality things. So I just said that this is one of this. We have almost like in India, 2,246 cath labs, which are all functioning. Out of that, we have 1,000 plus cath labs, which are functioning now of Philips. And then the other companies like 492, 365, and 387 for GE, Siemens, and other companies. It's been shared. We are proud to say that we are on the top. And because of you people have given the extending hands to us to work on in the different modalities, and we are very happy for that. And before that, so I just wanted to show you a video also here. In this tenure, so the thing was, I have some couple of videos also. We are talking about the radiation should be reduced in the cath lab, as well as the contrast also should be reduced, because these two are, many of the interventions are coming in the cath lab. We are talking about applications in the cath lab, but apart from that, the radiation and the priorities in the cath lab are radiation dose as well as the contrast dose should be minimized. So we have a one-end solution, and in the coronary as well as in the neuro also. We are talking about the previous. I have seen that some of the persons who has talked about dot balloon, which is more important in the cath lab. At least below the lesser the time of 20 to 30 minutes, at least 20 to 25 minutes. The patient's angioplasty. The patient has to move from the emergency, and the first balloon has to be done before the 20 minutes in the cath lab. This is mandatory in the cath lab, so that the values also. Maybe in India we don't have that. I have seen, in my experience, one of the consultant cardiologists has come from US. What he said, if the dot balloon time lesser than the 20 minutes they have not performed in the cath lab, they won't get money. They will not get money in US and UK. Either in the winter, it will be very difficult to come on to the hospital, right? In the US, still we are okay in India, right? So dot balloon time is much more important in the cath lab. If you not performing the case before the 20 minutes, the first balloon was not intervened in the cath lab, then the patient may not lose money, but the hospital will lose the money. But in Indian scenario, we don't have that. So in one-stop solution, I just want to show you this video from the cardiology, from the emergency room to the cath lab, how we are So this is the video. I just wanted to play this. How we
Through
are
treatment and follow-up care, Philips provides clinically efficient solutions to help support patient outcomes. By individualizing high-quality care for patients with coronary artery disease, or CAD, we provide solutions to help achieve a quick, confident diagnosis along with effective, efficient treatment. Let's look at the care pathway of Michael. He is 50 years old and experiencing weakness, lightheadedness, and pain in his shoulders. He has a family history of chronic stable angina, so he visits his cardiologist. The physician reviews his entire patient history with IntelliSpace Cardiovascular, an information management solution which simplifies the workflow with seamless access to multiple clinical tools. Lab exams are ordered and an echocardiography exam is performed on an Epic CVX. The sonographer may request additional assistance during the echo exam from the cardiologist using Collaboration Live. Additional analysis and assessment using TomTech Arena are integrated with the IntelliSpace Cardiovascular. CAD is suspected, so coronary CTA exam is performed on the spectral CT 7500 using a low volume of contrast. Results confirm multi-vessel disease with mixed plaque. Michael is transferred to the pre-procedure area to be prepped for a PCI. He's hooked up to the IntelliView X3, which is used throughout his stay, providing continuous monitoring between the prep area and the cath lab. In the cath lab, the IntelliView X3 is docked for connection to the Philips Hemo system, with no patient reconnections required. The Azurion with FlexVision Pro and the Expert IM provide the interventional cardiologist insights all in one place for easier planning. Using dynamic coronary roadmap with Azurion, the physician can see real-time guidance of the coronary arteries superimposed on live fluoroscopy. He also utilizes the intrasite workspace to measure the functional significance of the lesions with IFR using the OmniWire pressure guide wire. IVUS is then used to determine the characteristics of the lesion and the size of the vessel, so an effective, confident treatment plan can be made. Images are captured using the Eagle Eye Platinum catheter and show a need to debulk the lesion. The interventional cardiologist views and controls the necessary data at tableside without having to break scrub. To break up calcium and prep the vessel, laser atherectomy is performed using the Philips laser system to ensure safe and effective stent positioning. Finally, stents are properly placed with the help of IFR and IVUS co-registration in the occluded vessels to treat Michael's stenoses. Michael is carefully monitored on the IntelliView X3, and as he needs a little breathing support, he is put on the non-invasive Respironics V60. After
So the Azurion cath labs, which can integrate even the physiology, IVUS, hemosystems, angiogram, 3D imaging, informatics, everything can be included in one TSM, one touchscreen module in the examination room. Want to do an QCA, want to do an FFR, want to do an IFR, do an co-registration, and co-registration with the measurements, everything can be possible in one touch of TSM. That's what the intervention what we have now. So we have taken from the 2015, if you see the landmark of this and what we have taken already, the volcano which has been already taken for this. Because why I say Philips not only for the cath labs, in the beginning, as I mentioned very clearly, that light will not stop with one stop. Similarly, it is not only the imaging of the cath lab. It could be along with the volcano systems, IFR, FFR, and as well as we are talking about the devices also in the spectroanalytics. We have a laser here for the like calcification areas and all. We have a EPD solutions also in the cath lab. We have intact vascular, which is for the above knee and as well as the below knee also. We have a different balloons for that. And we have a Vasper medical also, then that is for the dual venous system where we have. So for the artery, it is an unstoppable solutions along with the cath lab, along with the imaging, along with the devices, diagnosis, everything. And in the cath lab, if we talk about, we have a separate suites for a different cases. So we have a coronary suite for coronary, which is including of a DCR, dynamic coronary roadmap, and a stent boost live. We have a EP suite, especially for to mapping LA, RA, especially for LA and pulmonary vein, because the difficulty in the cath lab, it is AF, atrial fibrillation. For that, we have an EP which is having highest modification in the cath labs, which you can check the calcification, you can do the marking in the cath lab. And why we are saying all this? Because in the cath lab, Up to 2000, we don't have the applications. We don't have a stent boost also in the cath lab. And I'm proud to say that if somebody is talking about maybe Siemens will talk about a clear stent live, GE may say that stent visible is live. But if you go to the customer, and customer will talk about stent boost first. It has been in a mandatory name for that, whether it could be in a company, irrespective of it could be a company of a GE or Siemens or any other company. So it has been means that was the pioneer it was done by the Philips. So now we see that we have an EP guided, we have a structural heart guided, it could be along with the echo machine, because see, earlier, if I say in one example that if somebody is asking that, where is your home? I need to give an address. So I need to say that which is my near point, I should state it. Then the person can reach to my home little earlier. Similarly, in the structural heart disease also, we need to keep a pigtail catheter to say that this is the area, the nearby area we need to poke. So now it is not required. With the Echo Navigator, which the Philips is providing, that it doesn't require any pigtail catheter. You can keep the marking over there because the TE probe can be registered under the fluoro in a different angulations. Once the TE probe got settled up already, then you can give the marking for any different areas of the ASD, VSD, leakages also can be done for most of the modality. And we have a vascular suit. And we have, for the neuro also, we have a different suits for that. We have an aneurysm flow. Because see, all these things were done in 2D blindly. I'm sorry to say this word, blindly we used to do. Now we require a mapping in the cath lab so that the consultant will be so fine to doing interventions. It could be in a cardiac side or it could be in a neuro side. So we have a DCR, I think most of the people have been using. We are also faced in the first generation of the DCR. There are some slight difficulty of the motion compensation because it has to work with the motion compensation. Yeah. Now the second advanced stage of DCR has come, which is having most of the motion compensation has been done successfully and will give the way. So there may be some of the other, there may be some competitors that may say that it is not working fine. I completely agree with that. But 80% of the time, we should have a way. If I say that I'm driving a car with my GPRS, I will find a different ways. I may see the difficulty while going the car, right? But you should have a way that while doing in a case. It is not that so blindly. And we have a DCR, so DCR can be like this. So with a different one, we can store multiple. With the DCR, it's been already proved that our fluoroscopic time has been decreased up to 30%, as well as the contrast medium also has been reduced up to 28% with the DCR. And it has been a proven results already. The second generation has come into the market already with this. And a stent boost live, which is having a third generation, which is there in 2002, it was only stent boost. The second generation, it has been come up with a stent boost subtraction. Now it is for stent boost live. Why to do all this after deploying the stent? If you wanted to do it on the time itself, you just deploy the stent, that to be without having much time. But don't worry about the radiation because we are not working with a 30 frames, it is only 15 frames, and which can be having also an equal radiation of 70 nanogray. And in the meanwhile, we can give the contrast also, a diluted contrast can also be given. You can see the stent boost subtraction also on the same time of stent boost live. Then we have a smart CT. So now earlier we used to call as a 3D roadmap, all this. Now it is smart CT, so that on the touch screen, and we are proud to say that on the touch screen itself, you can do segmentation. Like in IVUS, we will do a cross segmentation. Like similar kind of a cross segmentation also can be done in the cath lab with a smart CT. So you can provide everything on that. You can do a touch screen, and on the 2D image, if you wanted to keep a narrowing position, a marker to marker, you can give on that. And that will be replicated on the 2D also while doing an angioplasties. So that makes so easy for the consultant and cardiologist to make life very much easier. So all the things all in the TSM. Now the doctor should not come into the examination room even for the measurement or to an vessel analysis. It could be pre and post, everything. Means touchscreen module, what we have on the table side, you can do everything on the table side itself. So now for the neuro, we have a DTAS protocol. All of you, most of you people, of 80% of people in the neuro, stroke and all, now our prevention is, along with the cardiology, still from the last 4 years, it has been increasing. As for the NIC marketing also, it is clearly stating that neuro market, which is increasing. But apart from that, we have only 20 seconds, 10 seconds, 5 seconds CT in the cath lab. Now with this DTAS, we can do 7.8 seconds CT, helical CT, So normally a 3D rotation or a CT rotation in the cath lab, it is LAO 120 to RAO 120, a straight rotation. Now with this, it can include cranial and caudals also in the cath lab. And that to be with a lesser time, with a lesser dose. 7.8 seconds helical CT, which is a DTAS. What we are talking about? Direct to angio suit. Now the patient, even for a stroke also, should not go to the emergency room. He can come to the direct to the cath lab. And in the cath lab, we can do in a helical CT, we can see this entire the area, what was the volume got damaged in the cath lab itself with the help of a helical CT in the DTAS. And you can start the intervention, you can do the 4-vessel and intervention immediately on the table itself. So that we are talking about DTAs, direct to angio suit systems. So this is what it is for the mechanical
Every 2
thrombectomy.
seconds, someone on Earth is affected.
And apart from that, Philips is proudly say that it is introducing FORS technology also, fiber optic real shape. So now from the 2D, we are talking about only 2D angiogram. Most of the doctors, they may say that every people should go under the CT angiogram, right? After that, we should not. Even Dr. Devi Shetty was clearly mentioned in Karnataka, there was a progress also in that. We clearly said that after 35 to 40 years, everybody should go under the CT angio. Completely agree. After that, many of the cardiologists, they are still saying that you need to go for a 2D angiogram. But 2D angiogram, we were doing blindly. So that after that, we are getting the mapping now. The stent boost has come into the technology. Then after that, we came with mapping now. For the EP, we should have a mapping. Earlier now, J&J or St. Jude guys, they used to do the mapping in the EP. They used to say the doctor that, sir, we are here and you can manipulate it. So now it is not that. We can give the mapping, and the consultant from the cath lab itself, he can see the mapping even for a coronary structural heart disease. And for neuro also, now he can able to see on the monitor itself, even for a coronary also. Now, along with that, how to reduce the radiation dose? Still, my first point is, Philips is staying on the same first point, what I delivered already in the beginning, that even you have multiple options in the cath lab, but still we have to reduce the radiation dose. We have to reduce the contrast also. So for that, Philips, mostly by 2024, it is already in the program in our hands. 24 or 25, we are getting this technology. It has been already intervening in some of the areas also. With this, you just plan one. You can have a look on this. You just puncture it. Maybe take one fluorescent or take 3D. After that, no contrast, no radiation, without stopping the radiation, you can look on this. The catheter, the possibility we are talking about, similarly fiber optic catheter, which is with the fiber optic catheter, the catheter moves, you can able to see the anatomy, even for it could be AAA cases, or it for 3D cases, or for any other cases. So now, after that, we are into the HoloLens technology now. So this is going to be my last slide for this. So now what is this? So we are talking about 2D. After 2D, we are talking about mapping. After that, we are talking about that is fiber optic technology, which can reduce the radiation dose. And now, what is the fourth? At most, it also, we are working on that. Mostly by 2025, these two has to come into the market. So now it is HoloLens technology. Now the doctor, what he has to done? Just have a look on this video.
In the image-guided therapy business of Philips, one patient every single second somewhere on Earth is treated with one of our products. So that's 28 million patients a year could be treated because of the work that we do here. That was the big reason I came to Philips. Image-guided therapy is modern-day surgery without the incision. We're navigating tiny instruments through the body through incisions no larger than a pencil point. We're relying solely on X-ray images or medical imagery to guide us. So that means we are always looking at a screen of data.
With HoloLens, we can take it to the next level. We are a leader in image-guided therapy, and with Azurion, we created an industry-leading platform that customers really love. What's really cool about it is we've leveraged novel touchscreen technology to create a very powerful working spot for the physician. Our ultimate goal is to help doctors do procedures better, to help them innovate the procedure. With HoloLens, we can create a completely different experience, a working domain which is really tailored around the needs of the physician.
For complex procedures, physicians need to go from one screen to the other really rapidly. We can now get these screens to come in just by voice recognition, by eye tracking. This is all about efficiency. If patients are being treated and the procedure can be shortened, it's very beneficial for the patient.
At Philips, we strongly believe that technology is not the goal, technology should be the enabler. What we want is that the physician can just concentrate on the procedure and the patient, get them home faster and healthier. This partnership between Philips and Microsoft can have our users experience something completely new, something almost mind-blowing, something that they didn't think was possible, and help them improve care. That's a breakthrough. That's a complete game changer.
So I just said technology is never-ending process. So although in 90s we used to talk about only the cath labs, after that it has been intertwined into the flat detector, then the 2D has come, then road mapping has come. Only the 8 French catheter was there in the beginning, or 9 French catheter. Only the femoral access we used to do. After that, radial access has been coming to the market. Thousands of cases. Even if you see PAMI cases also can be done in the radials most of the times. So still we are talking about radiation and dose and all. And after that, new techniques have come to see the stent visualization, the TD. Then after that, it has come into the 3D mapping. Now we are talking about HoloLens and as well as fiber optic catheters also. So technology is never ending. There is no never ending procedure. And thanks for the opportunity. And I love to be thanks to everyone who are the audience here, who are sitting here, who has given me the opportunity, entire the group, entire the team. Thank you so much. Thanks a lot. Thank you. If any questions, please let me know. I hope we have finished on time.
Anyway, and Anjani, I never knew that you have shifted your field. I'm here. Anyway, it was a wonderful presentation. The innovation in technology plus your tongue may take Philips by in 80 years to double the orders.
Thank you. Thank you so much, Vijayanji. Thanks a lot. Thanks for the time.
Thank you. Then, yeah, I request Mr. Anjani to receive the memento from the moderators for your wonderful presentation. Yes, thank you. Next, we would let us invite Mr. Christopher Steelman from Weber State University, Salt Lake City, Utah, USA, and he'll be presenting about wholehearted validation and introduction to cardiovascular credentialing international. Let's invite Mr. Christopher Steelman onto the dais, please, with a huge round of applause.
How exciting was that? What an amazing profession we're involved in. Students, this is your future. Virtual reality, fiber optics. We're using things that we've never learned before. That got my heart racing. So, and I worry when it races, but I know one thing. If I were to have a coronary event today, I would be completely comfortable going to any hospital in India and being taken care of there. I've never been more impressed with the level of knowledge and just the attentiveness to detail by the technologists in this room. It's inspiring. I will go back to my country and tell them we can be like the Indians. We can have this, because this does not occur in the United States. There is no conference for cardiovascular technologists. We're a small part of cardiologist meetings or some other group. It's just a fabulous celebration of what we do. I'd like to thank the Society for having me here. I'd like to thank Weber State University for allowing me to come, giving me the time off, and especially thank someone very special in my life, who has allowed me to come during a holiday in the United States. So, cardiovascular credentialing. Those people enabled me to be here through their generosity. They provided me with this opportunity to speak to you earlier yesterday and also today. So, Cardiovascular Credentialing International. Our vision is to be the recognized credentialing agency for cardiovascular technology and emerging medical professionals. And I think we're achieving that. Our mission is to be an innovative, cost-effective organization driven by professional ethics and integrity, and through representation of professionals in providing recognized, high-quality, competency-based examinations. So why earn a credential? CCI has provided me this slide, and there are many reasons here. But I think the foremost reason is to differentiate ourselves from other professionals. See, in the United States, there are many, many schools teaching cardiovascular technology, and they all use different curriculums, different syllabi, different approaches to education. But everyone must pass this test. It is the standard across the United States to ensure that everyone has the basic knowledge and skills necessary to provide procedural assistance during cardiovascular procedures. So we're a nonprofit corporation. We deliver vital support to professional societies, credential holders, and educational programs. And we're headquartered in North Carolina in the United States, and we have been since 1968. And when I say we're the governing body. The board of CCI International is composed of a board of trustees and a board of advisors. And I am on the board of advisors for the invasive cardiovascular specialist community worldwide, just not in the United States. So 3 things to remember about CCI. We're the only credentialing organization focused specifically on the heart. There are many out there who provide services and credentials as part of another program. This is our entire focus. The other thing to remember is you are the heart of all that we do, and we celebrate your accomplishments. We celebrate the accomplishments, and we're investing. Our name is Cardiac Credentialing International, and that's the reason I'm here, to speak to the world about the cardiovascular profession. And I'll be doing so next month in Bangkok, Thailand. Wholehearted validation isn't just our tagline. It's why we exist. We have 26,000 credentialed individuals, and I'm proud to be able to introduce you to some of our certifications. Most people just think we do invasive cardiovascular specialties, but we're far more than that. Certified cardiographic technicians, those people who are doing stress tests, Holter monitoring, rhythm analysis technicians, whose job is to read and screen out ECG rhythms for physicians. We have an electrophysiology program, specifically for those that are working in electrophysiologic labs, cardiac sonographers, vascular specialists, and registered congenital cardiac sonographers. We're beginning to see more and more specialization within our profession. And so I think we'll soon see a pediatric certification, a fluoroscopy certification. So we are expanding. We are engaged in a profession where the evolution of technology is enabling procedures that we've not dreamed of before. And so we provide credentials recognizing your achievements in each one of those specialties. And of course, RCIS. So the journey is quite simple. You know, you create an account, select the exam that you'd like, select a pathway. So what do I mean about pathways? There are several ways in order that you can qualify for this test. Now in India, everyone's going to school, so you automatically qualify to take this test. You apply, you schedule to take the test through an exam center, you take and pass the exam, and then you welcome to the CCI family. Now, I say pathways, there's a lot of information here. And I'm not sure you can read it. I highly suggest that you go to our website, and it will explain to you There is qualification prerequisites and documentation needed for every specific exam. And you can find that on the internet very easily. Now, in the beginning, we used to be multiple choice questions. We're all familiar with that. One answer, 3 or 4 distractors, and it's a valid way to assess knowledge. But now the exam questions are getting more challenging. We have multiple response, so there's not just one answer. There might be 3 or 4 answers, and drag and drop. We are a visual specialty, so our test is becoming more visual. We need to be able to recognize things. So we have innovative items like drag and place, where we're taking the answers to the test and sliding them across and placing in the appropriate boxes. Hotspots, basically clicking on recognizing anatomy, recognizing vascular anatomy. And instead of answering a test, now we're looking at the visual component of that. So we're asking you to identify anatomy, identify pathology on actual angiograms, and drag in place. So how do we make this test? This is the exciting part. Now, I'm also proud to be on the exam committee for the RCIS. So several times a year, we all meet in Denver, Colorado, and we work with a professional testing organization. So we meet, CCI employs a professional testing service. They're called psychometricians. Their entire goal their entire specialty is writing tests. That's all they do. They study and put in place ways to assess knowledge in many fields, architecture, engineering, but also for the cardiovascular professionals. So they provide effective, valid, fair, reliable, and legally defensible evaluation service to ensure that the workforce is competent. And when I say to ensure the workforce is competent, it means, again, you have different ways of educating people. Which one is right? We recognize there are different ways for teachers to impart knowledge on students, but at the end, they all must end in the same place. They all must end being able to pass this test. So we do a task analysis. You know, if we wrote a test 5 years ago, which we did, it's not covering things like structural heart. It's not covering things than the newer technologies that are emerging today. So every several years, we send out a task analysis, and we ask people in cath labs, what are you doing? What are you currently doing in your cath labs? What is important to know? So it's not us guessing. There's very little guesswork involved with this. We ask hospital administrators, cath lab techs, nurses, to fill out a survey. What are you currently doing? And then we make our test based on that information. And then we discard many questions, things that are no longer relevant in our profession. And so part of our duties on the exam committee is looking at, are the questions relevant, or are they outdated? Are they accurate? And we look for cluing. What is cluing? So if you're very good at taking tests, you can see that if you go through a 150 question test, that a question might provide an answer to another question. And if you're smart, you just tag the question and see, well, maybe as I go forward, the answer will appear somewhere in a question. That doesn't happen with CCI questions. It is agonizingly painful to review 150 questions just on one exam, and there's 2 different versions of it. So the committee forms, and we sit and we go through each and every question. And we might debate a question for a half an hour. We might argue between ourselves, is this relevant? Is this right? Is it accurate? So it's a very meticulous situation. We bring together experts from around the country, and we also write questions. And if you've ever written questions for an exam, you know how detailed or how difficult it can be. It sounds easy, but it's not. So we have a specific handbook that guides us through this procedure. It's not an easy test. So I'll let you look at these pass rates for a second. This is for the RCIS exam. So you can see for first-time test takers, the first time you take the test, in July, which is the last published results, only 63% of the people who took this test passed it. And for all test takers. And that means people who have taken the test previously and have not done well, they have failed, and they come back to take it again. And the pass rate goes down to 56% for this exam. So it's not an easy test. It's a test you have to study. Because the things you commonly do in your cath lab, there will be questions about things that you do not do in your cath lab. That, we talk about information silos. We get very good at the specific things we do in our cath labs. But other cath labs do different procedures in different ways. So we need more global knowledge and not just specific to the tasks that we're doing every day. One of the interesting things is we added peripheral questions, because our task analysis recognized that in many cath labs, we're not just working on the heart, but we're working on legs and arms and limbs. And so there's an appropriate number of questions for those things as well on the RCIS exam. Now, if you're wondering about taking the test, and why would you take the test? In India, you don't really need it. But if you want to go abroad, it's universally recognized. If you want to differentiate yourself from the person who is also competing for the same job, in many countries, the RCIS will tell that employer they both have the similar education, they both have a clinical experience, but this person has an RCIS exam. They passed the international standard for knowledge in the cath lab community. So you can take this self-assessment. You go online, there's a nominal fee for that, and you can take the test in the comfort of your own home and see. Look at the items covering the appropriate proportion of subject matter. So what that means is, if there are 15 questions on the real test, on a specific item, there'll be 15 questions on the practice exam. So you know when you're done with this test, you have a pretty good idea that when you go to take the real exam, you'll do well. And if you're not, it's an indication. It points out your weaknesses. I've taken this test, this subject area, I did not do well. I'm going to focus on that now. So it helps guide us in the test take. So you've passed the test. You celebrate your success. So you can go on CCI International and get items like this to share on Facebook, to share on Twitter, to let people know that you're proud of your accomplishment. But that's only the beginning. The RCIS and these credentials are entry-level exams. We're not testing the experts. We're testing what does it take simply, what is the basic level of knowledge that a person needs to know to work in the cath lab. And we all know we have to keep up with that knowledge. So CCI requires continuing medical education. Every 3 years, you must submit 36 credentials. Now, I'd love to see a conference like this provide those kind of credentials. So not those credentials, but that continuing education units. So if you attend a conference like this, it would count towards your continuing education credits. And in this way, we can support our conferences, we can support our webinars, and they don't always have to be live. You can do this online, or you can simply read them. And the Educators Forum. CCI is dedicated. We know that successful educators foster successful students. So every year, we bring together educators all over the country. And this year, we're reaching out to the world, and we're saying, you're an educator, come to our conference just for you, just for educators. Number one, it's a tremendous opportunity for networking. You get to reach out to people. The friends I've met this weekend, I'll probably have 100 emails to go home and return, just for other cardiovascular technologists. Well, the education community is the same. So I would like to meet other educators, know what their challenges are, and hear the best practices. What techniques are teachers using to educate their students? And we have a grant. Now, I say students on top, but anyone can apply for this grant. The Aaron White Educational Grant rewards deserving students and CCI registrants who apply and meet the qualifications to receive an educational grant to attend an educational event. So you could apply for this grant and come to this conference next year and be assisted by CCI. And you can reach questions regarding that to the email on the bottom. Now, all of this information is available online, and I invite you to take a look at it. So now you're a member of the community. I'd like to call it a family. You know, I said this is Thanksgiving back in my home, the time of the year when everyone comes together. It's our second biggest holiday. And people ask me, will you miss your family? Will you miss being with your family? And I say to them, I am with my family. I am with the Cath Lab Technologists. These are my people. My family at home can wait. I get to see you once a year. So I am with family, and if I could I cannot think of a better way to spend a holiday. But you can find us on LinkedIn. You can find us on Facebook. And I hope Instagram. I would think we'll be there soon. So follow and like us. It's a tremendous place to keep up with information, changes in what's happening with CCI, and another way to connect. You know, before I wake up in the morning, or I wake up in the morning and before lunch, just because of Facebook, this simple social media, I can speak to anyone in the world. Someone in the Gambia, someone in India, someone all around the world. Hi, Chris, how are you doing? And it doesn't have to be a lengthy conversation. So we need to think of our community and our family, just not locally in terms of distance. We have support, we have people who support. And if you know any cardiovascular technologists, we're happy to share our knowledge. So I get on, hey, what are you doing for this right heart? Or what procedures are you doing? Or what gave you difficulty? And you can reach out to people around the world. There's a lot of controversy about social media. It can be like a knife. Used appropriately, it's a beautiful tool. Used inappropriately, we all know what can happen. So I invite you to join us on those social media sites. And CCI cannot exist without the feedback of the cardiovascular technologists and cardiac specialists throughout the world. So they provide a very simple way. Take a picture of this. Oh, I'm going to give you a second. And here's the reason why. Send them a message. We loved having Chris here. He should come back. I see him smiling there, right? Let CCI know that they should send representatives, not just me, but other representatives in the cardiovascular community, not just to India, but around the world. It's our name, Cardiac Credentialing International. Let's come together. This is a way you can tell them this was valuable. We appreciated having Chris come, and we would love to have him or someone else come to our next conference. So take a picture of this, because I want to meet you all. I think I've met more people this weekend than I've met in the last year. And it breaks my heart to leave. So please, let's keep in touch. I said yesterday when I ended, I don't end my speeches with thank you and all of these things. Let's continue this conversation. Feel free to reach out to me. I enjoy speaking. If you haven't noticed, I enjoy speaking to everyone in the world because I'm still learning. We're all still learning. My good friend in the front who's still learning. The people to the left of me and the founders, we're all still learning. We're learning from people who don't know a lot, and we're learning from people who know far more than us. So again, I thank you for this opportunity. Truly, it's been a thrill of my lifetime to be able to come here. So thank you all. Are there any questions?
Thank you, Christopher sir, for giving wonderful information about CCI and educating us for CCI. Thank you very much.
You're very welcome.
Yes. Thank you, Mr. Christopher Steinman, for your marvelous presentation, and requesting you to receive a memento from the moderators, and we shall give them a big round of applause. He's asking for a huge round of applause. Yeah, thank you. Yes, let's move on to the next topic, challenges in PTMC. And for this, let's invite Ms. Patmaja onto the stage, please. Ms. Patmaja from Jayadeva Hospital, Mysuru. With big round of applause, let's invite Ms. Patmaja.
Yeah, namaste. Good afternoon to one and all present here. Myself, Padmaja, Chief Lab Technician from Sri Jayadeva Institute of Cardiovascular Science and Research, Bangalore. Introducing myself, as a paramedic, I did my BSc course in Cardiac Care Technology as first batch of student in Jayadeva Institute under RGUHS. My journey of 23 years from a student to Chief Technician is a pleasure to dedicate my future service to the Institute. It's my pride to be the part of Jayadeva with the blessings of our beloved Director, Padma Shri Dr. C.N. Manjunath Sir, to work with him with the Institute's slogan, treatment first and payment next. About the Institute. Sri Jayadeva Institute of Cardiovascular Science and Research is a government-owned autonomous institute and is offering super specialty treatment to all cardiac patients, largest NABH accredited cardiac healthcare destination in Southeast Asia, having 17 cath labs, 14 OTs, non-invasive laboratories, and 24 hours ICU facilities. Balloon mitral valvotomy or PTMC
left ventricle.
using Acura or
More than a
Inouye
decade
balloon
ago,
is an effective
opening of
procedure
this
for
valve
management
needed
of
surgery.
patients with
Now,
rheumatic
it can be
mitral
done
stenosis.
by passing a
But
balloon
the
through a blood
inability to
vessel
cross the
in the
valve
thigh.
is
The
one of
balloon
the
is kept across the mitral.
pertinent reason for procedural failure. Continuing with my today's topic, balloon mitral valvotomy in difficult situation. BMV indications, symptomatic or less symptomatic mitral stenosis, severe MS with MVOA, mitral valve orifice area less than 1 cm square, pulmonary hypertension, episodic pulmonary edema, thromboembolectomy in moderate to severe MS, pregnancy with severe MS. Contraindications, LA body clot, more than grade 2 MR, selective bicommissional calcification, lack of expertise. Echo evolution. Echo evolution plays an important role for BMV procedure. Pre-procedure, we need to study the valve anatomy. Basically, through echo, we can know the morphology of the mitral valve, subvalvular apparatus, the distribution of calcium, mitral valve area, mitral valve gradients, PASP, commissural details, any evidence of LA thrombus, IAS profile, pericardial effusion. Mitral stenosis under echo. Coming to the important sector, the technically difficult situations of BMV. It can be at the level of transeptal puncture, abnormal septal profile, thick septum, bulging of IAS, septal aneurysm, double atrial membrane, dextrocardia, IVC anomaly. Next, at the level of crossing the mitral valve. Critical mitral stenosis lesser to 0.5 centimeter square, small LA, giant RA and small LA, thick IAS, severe submitral stenosis, unfavorable IAS puncture site. Methods of crossing the mitral valve. Either through Inouye method, changing the stillets, loop methods, push-pull technique, Swan-Ganz balloon assistance, Mayer's technique, modify Mayer's technique, and our director's Manjunath's techniques. Moving on, Technically challenging situations, most of the time our cath lab technologists face. Maybe the role starts from, technician's role starts from now. Entering into the LV, reshaping of the stellate to facilitate crossing the mitral valve. It depends on the puncture site, either it is low or high puncture, so that the stellate reshaping can be done. Crossing the valve in difficult cases, over the wire technique. In cases with critical mitral stenosis, and when there is abnormal bulge of the intra-atrial septum, the usual direct method of crossing the mitral valve may not be successful. So one of the BMV, out of our experience with modified technique of crossing the mitral valve over the wire technique, where in which LA guide wire is directly entered into the LV, as seen in the picture. After entering the LA guide wire, the loop is retained in the LV, so that the procedure, Akura balloon is taken over the LA guide wire and inflated to make the successful PTMC. Next, moving on. In case of large LA, the tips in the case of large LA, use PA angio for levo phase, increase the curvature of the puncture needle, so low puncture site, reshape the stellate over the wire technique, reverse loop of the balloon catheter. With these tips, one of these tips, the PTMC can be successful. There is the reverse loop technique. Dr. C.N. Manjunath has innovated a new technique of performing BNV in difficult cases. This is being called Manjunath's technique, which is a boon to poor patient using Akura balloon. Presence of LA clot thrombus classification is called Manjunath's classification of LA clot, which is as follows. Type 1A, LA appendage clot confined to appendage. Type 1B, LA appendage clot protruding to LA cavity. 2A, LA roof clot limited to plane above the fossa ovalis. 2B, below plane of fossa ovalis. 3, layered clot over IAS. 4, mobile clot attached to LA free wall. And last one, the ball valve thrombus. Highlights of thrombus correlating to the classification in echo. PTMC in LA clot. It can be done using Swan-Ganz balloon assistance, Mayer's technique, modify Mayer's techniques, modify over the wire technique. Swan-Ganz assisted LV entry. Balloon tip pulmonary artery catheter is taken to cross or enter the LV. Over the wire technique in case of LA clot and low IAS puncture. In case of submitral disease, high LA pressure despite moderate MS, disappropriate PAH, balloon impasses sign, difficulty in balloon reaching LV apex, frequent slipping of balloon during the inflation. This is one of the method, antegrade approach. Where LV entry using O35 thermo with 5FJR catheter. Next is the serial submitral dilatation of peripheral balloon. Exchange of LA guide wire, over which the procedure is finished using the Akura balloon. Moving on, one of the case, BMV using Akura balloon, 26 mm balloon, where the balloon catheter failed to enter the LV despite several attempts. So we tried with over the wire technique, where O25 coiled wire is directly placed in the LV and the balloon is passed over the wire. But again, we failed to reach the LV apex. Next, at this stage, we thought of failure to reach the LV apex was due to severe submitral disease. Hence, we plan to take the support of veno-arterial loop. Where O35 exchange length thermo guide wire introduced through Acura balloon catheter into LV, reaching to aorta. PTMC antegrade approach, we tried to pass the balloon over this. Still, balloon catheter failed to cross submitral apparatus. So, inflation of the proximal part of the balloon before the distal part. So, balloon impasse sign. What next? At this stage, we thought of dilating submitral disease with the peripheral angioplasty balloon retrogradely. Submitral release from retrograde approach. Peripheral balloon in shelf 18-60 peripheral angioplasty balloon introduced from arterial end towards the submitral apparatus and balloon is inflated. Submitral disease is dilated. Re-entry with Acura balloon into LV. Balloon could be introduced into LV easily and the valve was dilated successfully. So this is 26 Acura balloon with 23 cc volume. Successful BMV is done. To convince the BMV procedures successful rate, main thing is the hemodynamic criteria to be noted. Significant drop in RV pressure, where the pre-PTMC procedure, it was 142 mmHg and the post as 94. Significant drop in LA mean pre is 23 to 10. Mitral valve gradients 19 to 3. And coming to the conclusion, BMV is safe, effective across wide spectrum of clinical subset of patient with MS. BMV is guided, graded and gated procedure. Immediate and long-term results are good. The restenosis rate is low. Echocardiography during the procedure optimizes the outcome in technically difficult cases. Over-the-wire technique is useful in difficult entry situation and LA thrombus. Veno-arterial loop method using peripheral balloon for subvalvular stenosis is desirable. With this, I'd like to conclude my topic. Thanks for hearing my presentation. I'm grateful to ICVT for giving me the opportunity. Great day.
Thank you. Wonderful presentation. Please wait.
So can you please ask him? Instead of making the patient this one, everything if it is PE or PEG, it will be done in the echo lab only, sir. On table we don't do it because number of cases will be this. Any doubt, the cardiologist will roll out in the echo lab itself.
Thank you, Padmaja ma'am, and please receive a token of appreciation for your beautiful presentation. Big round of applause, yeah. Thank you, Padmaja ma'am. Please take your seat. And our next presenter of ICVT 2022 is Mr. Nibras from Medtronic, and he'll be speaking about technologically enhanced PTCE balloon to easier procedure. Let's invite Mr. Nibras with a big round of applause, everyone.
So good afternoon, everyone. I think before starting the presentation, I know that this question might come that why Medtronic had stopped Sprinter balloon. So the reason was very clear that Medtronic believes in the innovations and and making a meaningful difference by using the newer advanced technology that will enable all the technicians to do the daily procedure. So we have launched Euphora balloon almost around 6 months back with the intention that we are inspired by the customer needs and the feedback to get a best balloon in the market. So we, globally we took the feedback and received the inputs from around 2,000 plus intervention cardiologists and cath lab professionals. By doing that, we have created Euphora. So before coming to this slide, I believe everyone here agrees on the point that the Onyx has the best quality deliverability. So we have taken and used the same PowerTrack Medtronic trademark technology, which enables superior deliverability. Coming to the crossability profile, Euphora scores high because of the ultra thin material of balloon, which is 15% thinner than Sprinter itself. So as well as 9% lower profile. If I talk about the lower profile brand markers, which is 8% smaller, which is made up of platinum iridium, which provides you the better opacity. So if I talk about optimized mini wrap, which is again a Medtronic trademark technology, which is DuraTrack, which enables the for the proper deliverability as well. So here I'm talking about one-to-one comparison. It's better to have a one-to-one head-to-head comparison between Euphora and Sprinter. So here if you see the pushability for the Sprinter is 28% lesser. It means that 28% greater pushability force is from the sprint as far as Sprinter is concerned. So Euphora scores high as far as pushability is concerned. Similarly on the crossing profile, Euphora balloon has 3.6% less crossing profile over Sprinter balloons. So it's in the clear state, Euphora is a balloon of a choice where you are looking for superior deliverability. Again, the kissing balloon technique performance, here also Euphora scores higher, where the Euphora balloon has 17% less KBT insertion force and KBT refraction force also by 13%. So if I talk about the overall performance-wise for KBT performance, Euphora again scores high over Sprinter. So again, this is very important slide where if you see that Euphora balloon has 17.6% better recross profile. So lower is the recross profile, better is the the crossability. So if you see that Euphora balloon do have the 75, whereas the Sprinter do have 91s. So which clearly states that Euphora also cross better once the recross has been concerned. So we don't stop here. We have the expanded size matrix also, which we included and enhanced our 7 new additional lengths from 2.75 in all the quarters, 2.75, 3.25, and 3.75. So you don't have to compromise on the lesion length. So it's now NC Euphora, again the head-to-head comparison between the NC Sphora and NC Sprinters. So as you see that the tip is like 6% lower lesion entry profile, which ensures that this is the choice of the balloon for all the complex cases. So as you see here also, the NC Euphora scores high over the NC Sprinters. Similar to the NC Euphora, here pushability is 23% more and 12% better trackability as compared to the NC Sprinter. Coming to the next slides. So these slides, when like today in today's scenario where the strut thickness comes down to 61 micron, so radial growth and longitudinal growth becomes very important role because of these, the edge dissection and strut formation. So lower the radial growth is for the excellent precision. So it is very important perspective where the Euphora do have scores high over Sprinters in terms of radial growth and longitudinal growth as well. So again, this is also a very important part where the Euphora scores high on the durability of performance. Why I'm saying it, because Euphora has 5 times less likely tip catch rate during the stent recross. So the mean is like once the stent is deployed on the previous stent, the strut will be less in Euphora. So overall, if you talk about the best balloon to use in all the complex and bifurcation and left main cases, Euphora is the brand of choice for balloon for all these complex angiographies. Here also we didn't stop much, and we ensure that we have added 9 additional stents in the quarter size as well as full size also of 2.25, 4.50, and 50. So this is all about from my side. Thank you. Any questions, then probably we'll be happy to take that.
Just wanted to ask, it's a single fold balloon or it's multi-fold balloon?
So specifically, it's a multi-bolt.
Multi-fold balloon. Okay.
So if you talk about Sprinter, it is again as far as good as the Euphora balloon.
Okay. Okay.
Yeah.
Thank you. It was very good, informative lecture. Thank you. Just wait.
Thank you, and request Mr. Nipras to receive a memento from the moderators for his excellent presentation. Thank you. Thanks a lot. Please take your seat. And our next presenter is Mr. Ramasamy KJ, SMT representative from SMT, and he'll be presenting about an innovation powerhouse. Let's invite Mr. Ramasamy with a big round of applause. Thank you.
Good afternoon. So today we'll be talking about SMT. Every product of SMT has innovation that helps the physician and patient. So what are the products? What are the innovations we have done? What are the products? What is the innovation we have done? We will have a look at it. So about SMT, we are the #1 Indian DES company with 31% market share. We are the top 5 players in certain European markets, and we are present across 69 countries. Our revenue has been 688 crores for the year 2022, and we have 71 patents globally. We have 4 design registrations in India, 19 patents and 1 design registration in pipeline, 4 manufacturing facilities and 2 R&D facilities. We are committed for a vibrant R&D ecosystem for innovation, and as you can see here, our history of innovation right from 2005, we have developed our biodegradable polymer, ultra-thin stent with 60 micron stud thickness in 2005. And most of our products, including the DES, balloon catheters, TAVI, self-expanding delivery systems, are developed in-house. And we have 2 R&D facilities, one in India and one in Thailand, with strong partnership with Institute of Chemical Technology, Mumbai, and SVNIT, Surat. If you look at the R&D team, we have around 15 to 21 years of experience with the R&D team, and they are highly qualified. There is a dedicated team of 48 employees, and the team has been awarded Best R&D in Medical Devices. Like I said, we have the intellectual property of 71 patent grants, 19 patent in pipeline, 4 design registrations, 1 design registration in pipeline. So we also, if you look at the track record of innovation, especially in the usage of polymer technology in drug release and safety, we are the first company in the world to get a CE approval for DES with biodegradable polymer. The innovative polymer design for the optimal arterial healing and minimize side effects of the polymer, we have designed it. And in 2005, it all began with Infinium stent. And now if you look at it, again, we have specifically designed the biodegradable polymer. We are first in the world to have a blended polymer, biodegradable polymer, which gives unparalleled durability and prevent premature drug release. We have developed this technology for safe and effective delivery of 3 drugs, paclitaxel, sirolimus, and everolimus with biodegradable polymers. Some of our product innovations, in coronary intervention, in structural heart and peripheral interventions. If you look at these products, these are all our flagship products. Supraflex screws, and in the balloon catheters, it is Pipette. In TAVI, it is Hydra. In occluders, it is Cocoon. And in drug-coated balloon, it is Peripherix, which is a peripheral regulating balloon. So we will have a look at, what is been the innovation in each of these products from SMT's side. Supraflex screws, it is one of the most deliverable stent, sirolimus, eluting cobalt chromium stent with biodegradable polymer. Our biodegradable polymer has, the stent has got a conformal coating, and the polymer is, we are using three polymers, PVP, PLLA, and PLCL, and we have 3 layers of it. The top layer is a protective layer. It protects from light, moisture, premature drug release, and provides lubricity as well during stent implantation. The middle layer is same as the base layer with PLLA, PLCL, and sirolimus. This is designated to provide optimal amount of drug after stent implantation, and the base layer provides for a slow drug release. And there has been plenty of problems with deliverability in stents. So we had, we wanted to improve the trackability of our stent with 2.5 times of the predicate device. And we had developed almost more than 72 designs. And finally, we tested and we found our design with LDZ links. So what is this LDZ link all about? They are long connectors. These long connectors, it enhances the overall radial strength. It improves flexibility of the stent, and also, it transmits push force with higher efficiency, and it resists longitudinal compression. These are some of the case studies, case examples where, in tortuous and calcified RCA, multiple overlapping supraflex screw stents has been used, and the final TB flow was achieved. Like I said earlier in the beginning, supraflex screws is the most deliverable stent, and this study from the Future Cardiology, which was published, it shows that the mean track force required to track the stent is just 0.10 Newton. When compared with the current brands which is available in the market, this is the best deliverable stent available in the market. Next is the pipette NC balloon. Again, the next level of innovation from SMT as far as the balloon material and the balloon design is concerned. There has been always a problem which is associated with PTCA balloons. The balloons are stiff, they have a big profile, they are hard and thick material. With pipette NC, we have tried to sort most of these issues. We have best-in-class features. First thing is, the balloon has best-in-class shape memory. It is primarily due to the multi-layered balloon material. Even though the balloon is multi-layered, the balloon feels very soft, and the multi-layered has been fused in such a way that it is a single layer. With improved manufacturing process, the balloon's shape memory is also much better. And the average max force to recross, if you see, always there is a problem when you go from one lesion to another lesion. So the maximum force to recross is also much lesser when compared with the competition of 0.39 Newton. And even the track force is just 0.498 Newton when compared with, again, the competitors. So the major innovation what we have done is making the multi-layered balloon very thin with a very low profile. Next, in the next innovation what we are talking about, it is the peripheral drug-coated balloon, the paclitaxel drug-coated balloon called Peripherix. Here we have used a hybrid X2 technology where we have used hybrid paclitaxel and hybrid excipients. Basically, what we have done here is amorphous and crystalline paclitaxel, which is, paclitaxel in 2 forms. We have taken 2 excipients, the hydrophilic excipient and the lipophilic excipient, and we have formed a matrix in such a way that there is initial burst release with amorphous and hydrophilic excipient, and there is a sustained release with crystalline and lipophilic excipient. And the paclitaxel dose of 2 microgram per millimeter squared. And this is how the coating technology is. It is a proprietary coating technology which is coated on an inflated balloon with 360-degree coverage. If you look at this video, we are trying to show here, the hydration on the coating integrity. And if you look at it, there is negligible loss, when you look at the hydration when compared with the competition. We had, in this test, we had tested it for 2 minutes. We had kept in inflated balloon for 2 minutes. and then we had deflated it. And if you could see, even during inflation and deflation in some of the competitor balloons, you are seeing lots of drug loss. The amount of drug that is transferred with peripherics is almost 70% drug, with 5% drug loss, minimal drug loss which is there. This is primarily due to the hybrid X2 coating technology. Next, the structural heart space, we have Hydra. It is a self-expanding supraannular bovine pericardium. We have, done some subtle changes in this with the frame design, which enables a varying radial flows. If you look at the outflow part, you have a low radial force design. If you look at the high hoop strength at the mid frame and high radial force at the inflow part. This varying radial force helps to have a better trackability of the device. And we have also created the next generation AVDC with inline sheath and a unique active release for the first time in the world with a 14 French delivery system, which also has an active release feature. And if you look at some of the Hydra C studies, the excellent hemodynamics has been established as far as the the device is concerned. Single-digit valve gradient up to 1 year follow-up. And if you look at the paravalvular leak, there is a low rate of moderate to severe valvular leak. And even in NYHA functional class, close to 80% of the patients, they improved by more than one functional class, and 22% of the patients improved by more than two functional class. Next is the occluders. We have designed it to minimize the nickel leaching. Nickel leaching has been a common problem when when you look at the metal as nitinol. Occluders generally are made up of nitinol. So the disadvantage is that nickel can release into the bloodstream, and due to friction or corrosion, which can lead to the erosion of the occluder. And there can also be a need, where you have to go for a surgical intervention also. To avoid this complication, our Cocoon PF4 occluders, we use a proprietary platinum coating technology. So what makes it better is, with the platinum coating, the Cocoon occluders are inert, biocompatible, non-corrosive, and non-allergic, and also it enhances the radio opacity. So this is the raw nitinol. We have done the electropolishing, and this is how the final platinum coating product would look like. We are also humbled to get some of the meaningful award and recognitions, right from 2016 for the use of polymer in public healthcare. We got the national award, best quality in medical devices for the quality award, best R&D in medical devices in R&D awards. And as recent as 2022, we also have got the national award in for Supraflex Cruise for the best design award. And this is our product portfolio. We have been diversifying our portfolio through rich experience in intervention vascular device. In coronary, like I said, we have Supraflex Cruise and Star. In catheters, we have Vilma and Pipette. In accessories, we have the EC Catch Y connectors and Identity aspiration catheter. In structural heart, we have just seen Hydra and Cocoon. Peripheral intervention, we have drug-coated balloon peripherics, the renal system Renofit. And we also have the Cordis distribution products of catheters, balloons, vena cava filters, guide wire sheaths, and carotid stents. So this is what our upcoming innovations would be for the to the market. DEB in coronary. In the structural, we have LAA and the next generation TAVI device and delivery system. And in the peripheral segment, we are coming up with balloon mounted and self-expanding stent. So thank you all for giving me an opportunity, ICVT. Thank you.
Thank you. And Mr. Ramasamy, please receive memento on behalf of SPCIT for your wonderful presentation from the moderators. Please receive the memento. And we shall give them a big round of applause. Dear all, we are about to end the session within 2-3 discussions. Thank you. Yeah. Let's invite our next presenter, Mr. Sridhar. Chief Cardiac Technologist from MGM Healthcare, Chennai, and he'll be presenting about pediatric cardiac interventions. Yes, let's invite Mr. Sridhar onto the stage with a big round of applause. Everyone, come on please.
Good afternoon, everyone. My name is Sridhar from MGM Hospital, Chennai. Now I'm going to show you pediatric interventions. Pediatric cardiac intervention, most common AST, BST, PDA, BPV, BAV, unlimited coil stenting and PA stenting, PDA stenting, BS, RVO stenting and pendulation and AP windows and CF closure. See, this is for balloon arterial septostomy, emergency procedure, improved SpO2, TGA, right femoral vein, umbrella vein, recline and balloon. This 50 centimeter balloon. Next, AST closure, right femoral vein, usually LVPV, RVP, and LA root. Now, AST device we are implanting. This is 26 AST device deploying now through AP. This AST device closure with the balloon assisted effect rims. See, we are, before starting the case, we puncture for both femorally and right side and left side both femoral puncture was done. Then using for 34 mm AST balloon, sizing balloon through arm blaster 1 and deploying for device for AST device. We're deploying the AST device. This is a PDA device closure. This is right femoral vein, right femoral artery. Okay, ductal chloride, MFO, vascular flag. This is device we are applying MFO through lateral view. Now PDA device PA angiogram taken. PDA device closure through lateral view. We're deploying the device now. Then VSD device closure, defined venous side, arterial side. We taken puncture, we taken LAO cranial, LAO 20, cranial 40. We taken one view, we are deploying the VSD device from the arterial side. EST LV angiogram showed VSD properly we deployed there. This one more and CO stenting. So we taken AP view for CO stenting. We taken stent for deploying the PA side. See, now deployed the stent. Now taken the view, AP view. The PDA stent declarated right femoral vein, axillary artery, common aortic, stent by disc coronary stent. To stent disconnected PA. LPS stenting, we taken from the lateral view. LPS stenting. Cook formula stent was deployed here. RUST stenting, we taken, this is also same Cook stent only. Coronary fistula device closure, we taken AP cranial view through pictorial injection. You can see that leakage is from the right side to that coronary fistula. They are deployed for MO4 device through femoral vein. Thank you.
Thank you, and we request Mr. Sridhar to be on the stage, please, so that moderators could, if you have any doubts, please.
It was a short and sweet presentation of all the pediatric devices.
Thank you, sir.
It was informative. Thank you.
Thank you, sir.
Yes, big round of applause. Thank you, Mr. Sridhar. And let's move on to the last and final presentation, and it will be done by Mr. Vaidyanathan from MGM Hospital, Chennai, and he will be speaking about RSOV device closure. So let's invite Mr. Vaidyanathan with a big round of applause.
Thank you. Good afternoon to all. Introducing myself. I'm Vaidyanathan, Senior Technologist in MGM Healthcare, Chennai. Now I am presentation to RSOV device closure, rupture sinus of Valsalva device closure. Rupture sinus of Valsalva. Rupture sinus of Valsalva is rare but potentially life-threatening clinically entity which requires immediately recognition and then intervention. Presentation may range from an asymptomatic continuous murmur to acute cardiogenic shock and death. RSOV is either isolated lesion or associated with ventricular septal defect. Most of time, the VSD associated with RCC prolapse with RSOV are doubly committed VSDs. Symptoms: suddenly onset of breath illness and palpitations, signs, CVS, continuous murmur, signs of cardiac failure, echo. RSOV draining into RA or RV commonly, or aortic regurgitation, continuous flow from aorta to RA or RV. This is the image of rupture sinus of Valsalva to RA. This image shows only rupture sinus of Valsalva in RA. It looks like windsock. The echo shows RSOV. One second, I will play. RSOV treatment is one surgical closure, the second one is device closure. Transcatheter closure of rupture aneurysm of sinus of Valsalva was first performed by Coulinet al. at 1994 using a Raskine umbrella device. Rupture sinus of Valsalva device closure access will take R of a right femoral artery and then right femoral vein. AV loop formation, cross the RSOV from arterial side and snare it from the venous side. Device delivery sheath introduced through AV loop from venous side. Usually used devices PDA or MFO or ADO1. This is the angiogram, aortic angiogram of rupture sinus of Valsalva, and then pigtail also cross the aortic shoot, aortic, and then we'll take one RV angio shoot. Second one, we are crossing the thermo 260 extra stiff wire, cross the rupture sinus of Valsalva into the RV and then RVOT, and then snare it in then pulmonary artery and then snared. Snare it and then pull down in venous side. The next one is venous side. We are going to throw the mulline sheath in 7 French mulline sheath. We are deploying this device from the venous side only. We are successfully device MFO, LifeTech MFO device 10 by 12, and then aortic angiogram will show there are no valve leak. We have successfully implanted to the RSOV to RV device closure. Conclusion: RSOV device closure is effective method to treat RSOV compared to surgery. Occasionally, RSOV associated with small VSD which can be also be closed with device. Thank you.
Thank you, Mr. Vaidyanathan, and please receive a memento from the moderators for your presentation on RSOV closure. And that was the last and final talk for the 3-day long conference, that is International Conference for Cardiovascular Technologists, ICVT 2022, conducted by SPCIT, Society of Paramedics Cardiovascular Interventional Technologists. Hope you all enjoy the 3-day long scientific sessions by all the speakers, and I would like to thank all the speakers, presenters, moderators, judges, chairpersons. And next is the vote of thanks by Mr. Senthil Kumar, Junior Secretary, SPCIT. Thank you, Joint Secretary, SPCIT.
So good afternoon, everyone. It's a very few people are left in the audience. Anyway, we'll have to thank everyone as we have successfully completed this 3 days conference. So we would like to thank everyone of participants and delegates, doctors, foreign delegates, everyone who has participated in the conference, who has supported us in all the, through from media, and even our local MP has visited us yesterday evening. And everyone, each and everyone we thank from bottom of heart, and through Society SPCIT, from Society SPCIT of India. And we special thanks to, yesterday we had a small event who had forgotten our, one of the member of BAG, Mr. Manoj Sharma has returned back to the person. We thank you him also. And we have, this is the final event. We can have lunch and get back to our hometown. Thank you everyone.
Thank you, thanks a lot.